Hello, check. Hello. Hello, check. Hello. One, two, three. Hello. hello, hello. Hello, hello.
Very good morning to all of you. First of all, I welcome you all for the second event at our center, Her Health. And today I'm very much delighted to have international faculty, Dr. David Cummings, and my friend and younger brother, Dr. Mohit Bhandari. So today we are going to talk about obesity and the newer frontiers. There are a lot many things which are coming in. There are so many molecules which are new molecules, which will say. Recently there is a molecule which has been launched under the name of Mounjaro. So this once weekly anti-obesity medicine, it is a drug which is good for diabetes also. So let's hear from the horse's mouth. So first of all, I invite Dr. Mohit Bhandari. He will introduce the speaker to us because Dr. David Cummings needs a proper introduction. He's a man of metal and is someone who is known all over the world.
So, good morning, everybody. Thank you, Dr. Sachin, for such kind introduction. I'm a part of your family, so you don't need to welcome me, but I think Professor Cummings require introduction to justify his stature. Professor Cummings is a professor in University of Washington, Seattle, where he heads the Department of Endocrinology, Diabetes and Obesity. He has published more than 250 research articles in the field of obesity. And you know how I came across Professor Cummings, and there's a history to it. You know, obesity was a field governed and treated more by bariatric surgeons than physicians. And this was an era in 2010 when there were no drugs to treat obesity, and most of the physicians around the world were not very supportive of bariatric metabolic surgery. And there we met Professor Cummings, who at that point in time supported bariatric metabolic surgery, and he has evidence. You know, surgeons get emotional about surgery and about techniques they do, but Professor Cummings backed bariatric metabolic surgery way back in 2008 and 10 with evidence, literature, and lot of scientific prudence. And that's how we came in contact. And when I read about his research on obesity, you would have heard about the hormone ghrelin. He was one of those who involved to demonstrate it to the world how it causes obesity, along with obviously Professor Lee Kaplan and several others. And then about several other trials, including the Stampede trial, and now several other drugs like the GLP-1 analogs, which changed the way we looked at treatment of obesity, because something happened in 2022 when this drug came in USA. It changed the entire way even bariatric surgeons thought about obesity, and the credit to bring the research behind the GLP-1 analogs, the Ozempic and Mounjaro, which now half of the Hollywood and Bollywood is on, the credit goes to Professor Cummings. So last year we decided that running such a high volume bariatric center would not complete its aims and objectives without having him on board. So now he is with us, and we are moving to all parts of the country and the world to talk about the new molecules, the new kids on the block, the Ozempic and the Mounjaro. And I think we are extremely lucky and fortunate to have David Cummings speaking about it, because what he's going to speak, I can say that it's hardcore research, the latest, the cutting edge, and something which even is not in literature also. He's going to tell us about that. So Professor Cummings, thank you so much for joining us today at Bhopal. It was extremely busy. We went first to Gurgaon, New Delhi. We had a big support group, more than 200 patients, a lot of doctors. Then we went to Mumbai again. Without rest, he's traveling. Yesterday evening he came to Bhopal, and today I wanted to organize it at Bhopal. So thank you so much. I know you like to rest between the two support groups, but thank you so much. And tomorrow both of us are traveling to Hyderabad. So thank you so much. Please, the stage is all yours. And
hello, everybody. Welcome. Please, we should get my computer going. Yes. Thank you so much for coming. It's my pleasure to be here. I circulated beforehand and tried to meet each one of you personally. If I missed one or two in the back there, apologies, I didn't get to you. So we have to get my talk up here. Vishal, Shall I take that away? Yes. Give me about 2 minutes to get this connected.
You can place it on this.
On top? Okay. That's where it goes. Okay, excellent. Just one thing here. That's from today. Okay, great. Again, thank you so much for coming. It is going to be my pleasure today to talk to you about exciting, oh, and by the way, thank you for not asking me to speak in Hindi. And from my greetings of each of you, all of you speak some English, so thank you for that too. It'll be my pleasure today to talk to you about exciting new developments in obesity drugs. First, let me tell you a little bit in support of what Mohit said about who I am. I'm a professor of medicine at the University of Washington in Seattle, and I'm an endocrinologist. I'm not a surgeon, but I also have a role here. This is a picture from a few months ago of me joining as the sort of adjunct a faculty member, Mohit's wonderful institute in Indore, the SAMS, so Sri Aurobindo Institute of Medical Sciences. I want to make a quick note about Mohit. He is a surgeon, and he's a very, very active surgeon. I don't know of any surgeon in the world who has a higher caseload in metabolic surgery than he does. But unlike many surgeons who simply want to push surgery, he has a genuinely open mind that the goal is to treat obesity as a disease. Surgery is one of the tools, endoscopic bariatrics is another, and medicines are also perfectly fine. And the guy on the right there is Manuel Galvão Neto from Brazil, who's probably the world's leading bariatric endoscopist. He joined the group a few years ago, and then I have just recently joined as the director of metabolic medicine to form this triad of people that will be able to offer a multidisciplinary approach of various combinations of medical, endoscopic, and bariatric operations for obesity treatment. So I've been around a long time, and for most of the 35 years I've practiced obesity medicine as the founding director of the obesity management program in my hospital. We've muddled along with these drugs and phentermine and some other older ones, which these are the oral obesity meds, which in the aggregate cause about 5% weight loss. You know, it's statistically significant, but it's hardly life-changing. Then all that changed in 2021 with the introduction of semaglutide. It's branded under Ozempic or Wegovy. And this has really transformed the field. And there are other newer medicines that are on the market or coming, but they're all based on the same principle of semaglutide. I want to pause before I get into the details of this to reflect on how semaglutide was developed. It was developed in part based on studies into the mechanism by which bariatric metabolic surgery promotes reductions in body weight and glucose homeostasis. So that's the operation that was most studied. It's a gastric bypass. And back in about 2000, as an endocrinologist, it occurred to me that we should figure out how that thing works, because it was the most effective method of losing weight at the time. And if we could understand its mechanisms of action, maybe we could use that knowledge to develop medicines to recapitulate some of the effects of surgery without the operation. And beyond weight loss, it's incredibly effective about diabetes. So the majority of people who have type 2 diabetes will enjoy complete remission after that operation, usually long before they lose weight. So as an endocrinologist, that's what interested me and got me into the field. What are the mechanisms of that? And so beginning about the year 2000, I began to research that and also help promote research into that idea from a lot of other people as to ask the question, how does it work? And with 15 years of work on this, I and others put together a list of mechanisms by which it promotes diabetes remission and weight loss. It's a large list, But what I want to focus on are favorable changes in gut hormones. So among those, we found that gastric bypass greatly accentuates your body's own secretion of GLP-1, a gut hormone. So what does GLP-1 do? GLP-1 is a gut hormone from the distal intestine. It does a lot of things. What I want to focus on here is that it acts in the brain as a satiety peptide. So one of the reasons you feel full when you eat. So that helps you eat less. And in the GI system, it acts on the pancreas to stimulate insulin secretion, which helps with diabetes. By the way, in the gut, it also slows gastrointestinal motility, which is one of the reasons you feel full, and one of the mechanisms of its most common side effect, which is nausea or constipation. So what we found early on, this is my own data, but many people found this, after gastric bypass, GLP-1 secretion is greatly augmented. In the blue lines there, those are individuals with GLP-1 levels measured for a couple of hours after a meal, and they go up a little bit. And then in the same individuals, after their gastric bypass operation, in the purple, you see this tremendous augmentation of GLP-1 secretion. So these kind of findings identified GLP-1 as one of the mechanisms by which bypass surgery works, and therefore a good drug target to try to go after. And then many years later, semaglutide was developed as a medicinal form of GLP-1 and sold on the market specifically as a weight loss agent and a diabetes agent. So semaglutide now, in its, for example, first pivotal trial, step 1, promotes 15% body weight loss. So that's about 3 times more than any drug we'd ever had before it. There was concern, maybe this won't last because it's a modified peptide, and perhaps your immune system is going to develop antibodies against it, and that's going to attenuate the effect. Does that happen? Well, we don't have 10-year data yet, but the longest data we have comes here from the SELECT cardiovascular outcomes trial, and we see that the weight loss at more than 4 years seems unabated so far. So we all thought that semaglutide was the greatest thing since sliced bread. And shortly thereafter, an even better drug came around, tirzepatide, branded as Mounjaro or Zepbound. Tirzepatide has what semaglutide does, GLP-1 receptor agonist, and an additional thing, GIP receptor agonism. And here, it causes more like 21% weight loss. That's in people without diabetes. Now, historically, people with diabetes lose less body weight on weight loss medications than people without diabetes. And the same is true for tirzepatide and semaglutide. So here in the step 2 trial, you see the weight loss among people, all of whom had diabetes. And it's about 15%. So that's less than in people without diabetes. But I want to point out that 15% weight loss is the best pharmaceutical weight loss yet seen among people with diabetes. Moreover, in people with diabetes, you have this wonderful additional benefit that it helps the diabetes. So for example, here tirzepatide lowers A1C by about 2.2 points. So if your A1C started at 9, you go to 6.8. That's as powerful as any medicine we've seen except maybe insulin. Does this last, or is there going to be an immune-mediated attenuation of effects? Apparently not. This is the recent publication of SURMOUNT-1 showing the more than 3-year results that's maintained a 23% weight loss at least as long as 3 years. And by the way, everybody in this study had pre-diabetes, and by the end of the study, 95% of them had reverted to normal glycemia and no longer had pre-diabetes. So it's very clear that these drugs, both semaglutide and tirzepatide, are terrific at what they were designed to do, promote weight loss and improve diabetes. With that comes corollary benefits on blood pressure and lipids. That's been shown in many trials. I want to focus now on newer data, all within the last year, on other benefits on harder outcomes. So everything I'm about to show you are papers published from randomized trials in usually the New England Journal of Medicine or something at that level. The first shows with these drugs improvements in major adverse kidney events among people in an RCT of semaglutide versus placebo. So what is that? That's like dying of kidney disease, getting a kidney transplant, or having dialysis initiated. A really hard endpoint that matters to patients. Similarly, GLP-1 drugs have been shown in an RCT to reduce major adverse liver events. That would be dying of liver disease, getting a liver transplant, or developing new cirrhosis. Another paper in the New England Journal was a major improvement with these medicines in sleep apnea, with a 50% reduction in apnea-hypopnea index, which is as good as, or better than any known drug, and only beaten by CPAP, which nobody likes to use. Another New England Journal paper showing improvements in clinically significant osteoarthritis symptoms, congestive heart failure as well. How about the all-important one that people care about? The gentleman with the wonderful mustache will care about this, the cardiovascular outcomes. You're the cardiologist, right? He's the cardiologist, sorry. So no weight loss drug has been shown to affect cardiovascular outcomes until now. The SELECT trial was a proper cardiovascular outcomes trial that showed semaglutide reduced cardiovascular events, heart attacks and strokes, or cardiovascular death by 20% in people without diabetes, and prior to that in the SUSTAIN 6 trial by 26% among people with diabetes. So we can add to this list of very important clinical outcomes shown to be improved by these GLP-1 drugs, major adverse cardiovascular events. How about cancer? So the cancer is a special case because there was concern initially that they might actually increase cancer. Part of that comes from the fact that in toxicology studies, rats experienced increased risk of medullary thyroid cancer, a very rare form of cancer. And there's some theoretical concern that the drugs could promote pancreatic cancer. Has that panned out so far? The answer is no. There's several new studies on this. I'll just quote one of them. Meta-analysis, 37 randomized trials and 19 real-world studies, and of 36,500 people. And then the bottom line was they showed no association of GLP-1 use with any change in the risk of cancers, including thyroid and pancreatic. Beyond this and other studies showing no increased risk, there are actually studies showing decreased risk of some obesity-associated cancers. So here's a study of 1.7 million people, published just recently in JAMA Network Open. And you can see that this is a study of people who are taking GLP-1s versus something else for their diabetes. And you can see that compared to those taking insulin, the one on GLP-1s had a lower incidence of colorectal cancer, and they had a similar lower incidence of liver cancer. In fact, of the 13 known obesity-associated cancers, 12 of them in this study were shown to be reduced in people taking GLP-1s compared to those not taking GLP-1s. That makes sense because the drugs lower obesity, and so they're going to presumably help with obesity-related cancers and do so on at least 10 of the 13. This slide is impossible to read, but I show it because I think it's a very important paper just published recently in Nature Medicine. I'll tell you what it shows. It was a study of 2.5 million people taking GLP-1s, and the question was asked, what diagnoses are more or less common in them compared to people not taking GLP-1s? This is a fishing experiment, a sort of a net thing, to see if they can find any pluses and minuses of the effects of GLP-1. On the left are illnesses or diagnostic codes found to be less common among people on GLP-1s compared to not. On the right are diseases that were more common. Visually, you might be able to see there's more stuff in the less common diseases category than there are diseases that are more common with GLP-1. In the more common category were things we would expect. So there are a bunch of things related to GI side effects, more pancreatitis, a rare form of interstitial nephritis, and some kidney stones. Nothing super serious. In the less common thing, diagnoses that were less common among people with GLP-1 usage, there were the things you'd expect. Fewer liver disease, kidney disease, heart disease, the things I just shown you to be proven in those RCTs. So that makes you faithful that this was a valid study. What was interesting in this fishing net experiment were the things that came up to be surprising. I want to focus on 3 of them. One was less common suicide and self-harm, alcohol and substance abuse, and Alzheimer's disease. Now, were any of these things actually true? So in a fishing experiments like this, you can get some hits that are that sort of flukes. But each one of these has been looked into in greater depth in other studies that have just come out in the last few months. So let's look at suicide and self-harm first. That's of special interest because semaglutide, when it was first marketed, was coded as being a special concern for suicide. It actually had a black box contraindication to be used in anybody who had suicidal thoughts. The reason was just because older oral drugs for obesity had been associated with increased risk of suicide, and out of caution, the folks who sold this stuff did the same for semaglutide. Has that actually proven to be true? Well, here's an RCT. Sorry, it's a meta-analysis of RCTs. They looked at 27 randomized trials in which people were placed on semaglutide or placebo for other reasons, for diabetes or obesity. And none of them were designed for suicide as the endpoint. But the question was, among 59,500 people studied for more than 140,000 people years of follow-up, was there any evidence that in the aggregate there was more suicide or less in the people randomly allocated to get GLP-1s? So the endpoint in this meta-analysis was anything related to do with suicide attempts, successes, or ideation, or self-harm. Here are the results. So this is a forest plot, and if the dots are in the middle, that means there's no difference in the people taking GLP-1s or not. And they're all in the middle. There's no difference in suicidality among people with diabetes, and here are the studies without diabetes, also no incidence there. So it doesn't say that suicidality has helped with GLP-1s, but it puts to rest the notion that there'd be any concern. Beyond that, there was one study done in children recently, in adolescents, looking at suicidality there that suggests actually suicides might be less common on GLP-1s. So in this study of 54,000+ people, adolescents, suicide attempts and thoughts were found to be less common among those getting GLP-1s. And we will see whether that proves to be a truism or not. It hasn't been subjected to randomized trials. But at the very least, we don't have to worry suicidality is made more likely with GLP-1s. The next thing was, in that fishing experiment, was that people with alcohol abuse were found to be less common among those taking GLP-1. This has been studied in a randomized trial separate from that. A recent thing published in JAMA Psychiatry about 2 months ago is a randomized trial where they took people with alcohol abuse disorder and put them in an environment with lots of alcohol. And then they were randomly allocated to be getting GLP-1s or a placebo, and they didn't know which they were getting. What they found was that those who happened to be on GLP-1s had less drinking, lower alcohol blood levels, fewer cravings for alcohol, especially less heavy drinking, and by the way, those who smoked ended up smoking less. So this adds to a growing body of literature that the GLP-1s seem to help with what we might call compulsive behaviors. Other studies have shown them to reduce other drugs of abuse, as well as compulsive gambling, and even compulsive shopping. I have been thinking of maybe prescribing my wife this medicine, even though her BMI is like 17. So it might be that this is a direct effect of GLP-1s in the mesolimbic dopaminergic midbrain reward center, and that these drugs help with the compulsive behaviors that are rewarded by various things, and perhaps that contributes to its effect on food intake as well. Finally, in that fishing experiment, they found less Alzheimer's disease among people taking GLP-1s. Does that hold up to be true or not? That's kind of the least developed hypothesis, but it's certainly a gold mine if it proves to be true. There was a recent meta-analysis on this published, about 4 weeks ago in JAMA Neurology. It's a meta-analysis of 26 randomized controlled trials of people who got one or the other drug for diabetes versus placebo. And then the question was, these, although none of them were about dementia, they all reported dementia-related things as secondary outcomes. In the aggregate, was there any difference in those secondary outcomes among all of these studies of people randomly allocated to get various diabetes drugs or placebo? It turns out that those who got GLP-1 had a 45% lower incidence, odds ratio of all-cause dementia indicators compared to placebo. Interestingly and importantly, the same finding was not found with any of the other diabetes drug medicines. So no pioglitazone, SGLT2s, insulin, or anything like that. So that suggests that it's not simply improving the diabetes that improved the dementia, but something specifically about the GLP-1's action that might improve dementia. Now this needs to be verified in a randomized trial. That kind of trial is probably going to be so long I won't even live to see it, but it's certainly an interesting promise. Now, what about concerns, possible concerns? First of all, the biggest concern, the most common one, is side effects, and I'll summarize that by just saying GLP-1 receptor agonists sometimes cause GI symptoms. It's a minority of patients. It's going to be either nausea, constipation, or diarrhea. The first two just representing the mode of action carried a little too far in an individual. So one of the ways that GLP-1s make you feel full is they slow GI motility. If that happens in your stomach, you might get nauseated if you go too far. And if it goes too far in your lower intestine, you might have constipation. The answer is just back down on the dose to the highest dose you could tolerate. I have no idea why some people have diarrhea. That's a weird one. But I'm told that here in India, you're all worried about lean body mass. That seems to be a big concern in a country with a lot of vegetarians who may have less protein intake. So the question is, when you lose weight with semaglutide or tirzepatide, will you lose lean body mass? Answer, yes, you will. You also would if you lost weight with a diet, or if you had bariatric surgery, or if you had a balloon, and various endoscopic means. Some loss of lean body mass accompanies weight loss from any mechanism, except if you lose weight simply by exercising, and that's the only thing you do. So that's just a thing with weight loss. Here's an example. This is the relationship between fat mass loss and lean body mass loss by GLP-1s or diet or bariatric surgery. And they all have about the same relationship. Roughly, when you lose weight, about 25% of it is going to be lean, and the other 75% will be fat. The big question is, how does that loss of 25% lean body mass translate into mobility, which is what patients care about? And the answer is, your mobility will increase when you lose weight, because the small compromise of lean body mass and maybe muscle mass is more than compensated for by the ability to move around better when you don't weigh so much, to get up off the floor after playing with your grandchildren or rise from a chair. We can see this with bariatric surgery. They lose even more lean body mass and more weight, and their mobility greatly increases. There's no special effect of GLP-1s to reduce lean body mass from a mechanism beyond just the effect of weight loss alone. And there are studies now that show that this can be mediated, this can be ameliorated. Some strategies to reduce that would be try to keep your protein level up, have a high protein diet. If you're a vegetarian, that has to be plant protein. And of course, if you can do resistance exercise, that will help as well. I mentioned, by the way, that some of the loss in fat, volume, and weight, just in a paper that I haven't put in here, was published like this week, using magnetic resonance spectroscopy, some of the loss of that mass with GLP-1s comes from reduction of the fat within the mass, which is a good thing. And of course, there are drugs coming in the pipeline that promise to cause weight loss with absolutely no loss in lean body mass. So those are exciting new prospects, but they're not on the market yet. Speaking of drugs in the pipeline, let me just quickly mention it is a very exciting time. There are a lot of them. The most well-developed is retatrutide. That's like semaglutide, GLP-1, and tirzepatide, GIP, and it also adds a glucagon receptor agonist to it. And in its one published pivotal trial, that's in the New England Journal a little while ago, it caused 24% weight loss, the highest we've seen from any drug so far. We will see what happens with that. It's working its way through the pipeline to be marketed, but it's not marketed yet. And then there's a whole list of other drugs coming through the pipeline. It's a very exciting time in pharmaceutical weight loss. Generally speaking, this list has GLP-1 receptor agonism plus something else. either amylin agonist, GIP agonism or antagonism, glucagon agonism or antagonism. The only other thing that doesn't have GLP-1 are the activin antagonists, and they're the ones that promote lean body mass. So it's a fun time to be in the field, but these drugs are coming through. They're not yet marketed. I want to point out some major limitations to the drugs I've just been talking about. As great as semaglutide and tirzepatide are, and I'm certainly a fan, they do have some important shortcomings. The first one is the answer to this question that is the most common question I get from the 1,000 or so people I put on either one of these drugs. Hey doc, how long am I going to have to take this medicine? Everybody wants to take it to lose weight and then go off of it. And the question pertains to the answer to this question: do the drugs confer any benefit after you stop them? Well, that's been studied. Here, for example, in the SURMOUNT-4 trial, people were placed on tirzepatide. They lost the typical 21% of body weight loss. And then they were randomly allocated to continue on tirzepatide or go on to placebo in a blinded manner. The folks lucky enough to stay on tirzepatide continued to lose weight and got down to minus 26%. And those unlucky enough to go to placebo shot right back up, gaining more than half of their lost weight within the period of the study. This and several similar studies show that by 1 year after stopping GLP-1s, almost all of your weight that you lost will be regained. All of the benefits on diabetes will be lost, as well as all the peripheral benefits on other things. The drugs don't work if you don't take them. They wouldn't be predicted to. So in answer to the question, how long am I going to have to take this, doc? The answer is, unfortunately, it's a life sentence. The FDA in my country, the organization that approves drugs, has officially coded these drugs as what they call forever drugs, anticipated to be used for your lifetime. So that leads to the problem number 2. At least where I come from, they're crazy expensive. I know it's going to be structured differently here, but I'm going to speak now in American terms because that's the data I'm familiar with. How expensive are they? Well, semaglutide or tirzepatide in the United States costs between $900 and $1,350 a month. To put that in perspective, metabolic bariatric surgery costs between $17,000 and $26,000 for most people done once, and then you're set for life. The bottom line is that in less than 2 years of taking semaglutide or tirzepatide, you could have bought a gastric bypass, and that would have satisfied you for life. Instead, you have to be on this drug, which won't work unless you take it for your whole life. That's the cost in absolute terms. What about cost per benefit gained? So we express that as the cost for quality adjusted life here, and a construct of what it costs for 1 year of perfect life. So metabolic surgery costs about $10,000 to $25,000 per quality adjusted life year. That's about 5 to 10 times cheaper than most we usually accept as a societally accepted standard for affordable health care paid for by insurance. Tirzepatide or semaglutide cost a stunning $1.1 million per quality adjusted life year. 10 times more expensive than the usual societally accepted standard for affordable healthcare interventions. It's kind of stunning to me that any insurance companies pay for this at all, and they are increasingly not paying for it in my country. And this leads to the quote that was coined by Carl Leroux: metabolic surgery ain't so sexy anymore, but it's cheap. A funny thing, since the cost of surgery used to be a barrier, but by now it's dirt cheap by comparison to these crazy medicines. Semaglutide is already the #1 drug in the United States for cost. And there was a publication just recently in JAMA Cardiology calculating that more than half of Americans qualify for these drugs based on their original criteria. So what would it cost if we put everybody who qualified for the medicine on it? I ran that calculation and it would be $2.4 trillion a year. How expensive is that? Well, that's 3 times what the American government spends on defense. And we spend more on defense than the next top 10 countries on defense combined, including China and Russia and other big ones, and India. So it's a crazy number that we would never be able to afford. So this cost adds to many other things that lead to these very difficult troubles in access, at least where I come from. Supply chain failures that keep on persisting as well, global shortages, and patchy insurance company coverage, which is getting less and less. So all that conspires to give these results, published just recently in JAMA Network Open, looking at the percentage of people who start a GLP-1 drug who continue on it over time. And in this, for people taking it without diabetes, at 1 year, more than 60% had already discontinued it, and at 2 years, 83% were off the med. That's despite the fact you have to take it for it to work. So were these people coming off because they had side effects? No. In my experience with 1,000 or so prescriptions, fewer than 5% of people who go on these drugs have to be ripped off them because of side effects. The vast majority of these early discontinuations are coming because people are having the drug they liked torn away from them because they paid for it themselves and ran out of money. Their insurance company used to pay for it and stopped, or the supply chain troubles just happened and they couldn't get the damn thing. I want to close by just mentioning this important fact. Despite the new drugs and how great they are, again, I'm a fan, it is still not the case that they're as good as metabolic surgery for any endpoint. Metabolic surgery, or what you might call bariatric surgery, is still more effective than any known medicine at everything I've talked about. Reductions in body weight, diabetes improvement, as well as improvements in major adverse liver, kidney, cardiovascular events. I could show you a long slide that says the effect sizes for each, but for example, taking major adverse liver events, the effect size for that with semaglutide was a reduction of 22%. For bariatric surgery, it's, what was it, 72 to 88% reduction in major adverse liver outcomes as per the Splendor and Special trials recently published. So surgery is still more effective. And the important thing is you don't have to choose between surgery and medicines. I go to a lot of surgical meetings where there are these debates about this operation versus that operation. The two guys will get up and fight each other. Or is it surgery or endoscopy, or surgery or medicine? It's kind of a false comparison. There's no reason they need to be or. Here are a whole list of studies showing that these new drugs work in addition to surgery to augment its benefits. Even though, surprisingly, they're GLP-1 receptor agonists and natural GLP-1 goes up a lot. Despite that, people taking them will do better if they lost weight and regained it, if they never lost weight in the first place, if their diabetes went away and came back. You can get more benefit when you add a medicine to the operations. And that points out, like, maybe my most important message to you folks. There's no reason that we have to be talking about surgeons versus physicians. We all should be working as a unified team of surgeons and internists and exercise physiologists and dietitians and nurses, educators, policymakers, everybody working together as a unified team together against a common foe. That adversary is obesity. And for the moment, at least, obesity is winning this game, despite our best efforts. Here's a paper published 6 days ago in Lancet Diabetes Endocrinology showing obesity rates in my country. And you can see at every category, they continue to rise. And this goes out long enough that the new medicines are included in it. There's especially a huge rise in our severe obesity. So the only way we're going to have a chance to combat this problem is to work together as a team, which is why I like Mohit's program so much, because he really embraces the philosophy that we all need to work together for these things: surgery, endoscopy, medicines, behavioral effects. I've had the pleasure to work with many talented colleagues at the University of Washington throughout my career, and many cherished colleagues abroad. I thank them for their work, and I thank you all for your kind attention.
Thank you, Dr. Cummings, for a very enlightening lecture. I think the crowd is now ready for the battery of questions, and at least should be fired to the. It should be actually coming from the horse's mouth. So this is the right time to take that opportunity. A person who is behind the development of the drug called Mounjaro. So let's ask him what else we can learn which has not been given in the books, because he is right over here. So let's take it as a feast. The house is open for questions.
I also have a lot of personal experience prescribing semaglutide and tirzepatide.
Yeah. So let's come to the dosage part.
Sure.
People are, right now, we are raw with respect to Mounjaro. We'd like to hear from you how we should start with Mounjaro treatment.
Oh, sure. So the trials that got, the pivotal trials for semaglutide for the moment are called STEP. And they have two meanings, a little bit like about the name of Pakistan has two different meanings. You step up the doses from small to higher over several months. In addition, STEP means semaglutide treatment effect in people. So it's a dual meaning. And the same is true with Mounjaro. That is started at a low dose and escalated. You want to hear about Mounjaro. So the starting dose is 2.5 milligrams a week. And both of these drugs are weekly injections. And then it goes 2.5, 5, 7.5, 10, 12.5, 15. 15 is the maximum dose. There are some studies not yet published at looking at higher doses. I'm told that they have even more weight loss, but they're not yet approved. In this country, I think tirzepatide, Mounjaro, is only available at the up to
2.5 and 5.
0.5 and 5. But Lilly people at a lecture I gave 2 days ago said you're going to get the whole thing in the next couple of months. So you were limited to about 1/3 the maximum dose now, but that's a short-lived thing. Also, the injection occurs with a pen. And I didn't mention this, but one of the concerns for patients is, can I possibly inject myself? That seems really intimidating. I work at a VA hospital, veterans, and there are many people suffering from post-traumatic stress disorder. And one of that manifestations is severe needle phobia in many of my patients. Despite that, the needles associated with semaglutide and tirzepatide are a different beast. It's a little pen, you click it, and the needle comes out, and you can barely see it. It's so short and so small that even my patients with severe needle phobia don't seem to be having any trouble. They get over that and inject it. There's also drugs coming through the pipeline that will be injected once a month, not once a week. So the injections are not a big problem. Once you guys get the injector devices, they're not available in India, but they will be in a few months,
Yeah.
I'm told.
Right now, we are injecting with a insulin syringe.
Yeah, so that does bring up needle phobia issues, but it's a short-lived problem. So in answer to your question, you start at 2.5 up to 5 and so on. If you get up, 7.5, 10, 12.5, 15, if you start running into side effects at any point, usually the most common is nausea. The important thing is don't scrap the medicine altogether. Try to back down to the last dose you could tolerate, because the medicines do work at lower doses, just not as well. And almost everybody can tolerate some dose of it. So if you have side effects, back down to the maximally effective, maximally tolerated dose. Hi, yeah.
Are there any known drug interactions? That's my first question. Second is, children with attention deficit hyperactivity disorder, they end up with obesity when they are adolescent or adults. And quite a few of them are on neurostimulants. So can these drugs be given with stimulants?
Okay, so the first question, are there any known drug interactions with semaglutide or tirzepatide? I'm not aware of any. I haven't heard of any in the literature, and I see no mechanistic reason to suspect them. I welcome the audience to participate. I don't know everything. Does anybody know of a drug-drug interaction of GLP-1s with anything else?
Can give them in attention deficit disorder.
Well, I wasn't, that's,
The only thing is in India it's not approved for an age below 60 years. That's the problem, but we can give it.
so that was the second question. They're not contraindicated in ADHD. That said, though, I have no reason to believe they would help ADHD the way Ativan does. So some of the common ADHD drugs, methylphenidate, they promote weight loss and help ADHD. And so they hit two birds with one stone. The GLP-1 drugs will cause weight loss and improve diabetes. I don't have any reason to believe they would worsen or help ADHD. The methylphenidate has great black market potential in universities in my country because it has 3 effects. helps you concentrate for the test you're about to take the next day, helps you stay up at night so you can take the test, and helps you lose weight so you can look good on the dating scene. And so a lot of people who have the disease get their drugs and sell them to their fellow students. Yes.
I'm Dr. Sanjay Gupta. I am a nephrologist here.
Yes, Dr. Gupta.
See, you showed so many benefits with as far as the kidney endpoints are concerned. The kidney health is concerned with GLP-1 analogs. Obesity is an epidemic, and our Prime Minister, Mr. Narendra Modi, recently addressed this issue publicly by changing our lifestyles, etc., not going for the meds. So that is there. So recently, there has been a trend in our Bollywood to take Ozempic as an anti-obesity measure. And I had gone through social media, so many of them, I don't want to name them, but they are very prominent Bollywood figures in India.
I know.
They are looking pitiable. They've gone so thin and lean. People have started commenting that either they've gone sick or they have become diabetic, although they are not. So that was the issue which you raised here, that lean body mass gone down. Is there? Yeah.
Yeah, they call it Ozempic. It's called Ozempic face.
Ozempic.
Ozempic face. It's
So
kind of a
I
skinny face.
I think most of the GLP-1 analogs or GIP-1 analogs, they have this effect. So are there any experiments or trials whether anabolic steroids, giving anabolic steroids, etc., may reduce the
Offset the effect.
loss of lean body mass?
Not that I'm aware of. That doesn't mean they don't exist, but I have not seen anything published. I think the greater activity in that space is among the activin antagonists that are coming through the pipeline. Those are being tested in combination with GLP-1 because activin antagonism directly stimulates muscle growth. And also, by the way, those drugs cause weight loss. So either used singly or as adjuncts to GLP-1s, they promise to help mitigate the lean body mass loss. Now, the thing with Ozempic face, the loss of this, what you're talking about is Bollywood stars, or in my country, Hollywood stars, that might have been pretty thin in the first place. So when they lose even more weight, they may look sort of unnaturally thin. If you start out very heavy and are the more appropriate for the use of these drugs, you're probably not going to get Bollywood face. By the way, on an ethical basis,
ये पूछना है कि इन दवाओं का मरीज की नींद पे क्या असर होता है?
Is there any effect of these drugs on the sleep pattern?
sleep pattern?
Yeah.
Well, obstructive sleep apnea is greatly improved. I'm not sure if there's any evidence on sleep patterns per se, except OSA. And there was one study published within the last year in New England Journal of Medicine that showed in a randomized trial, blinded, versus semaglutide versus placebo, the apnea-hypopnea index was reduced by 50% with the drug. So it is now FDA approved in my country for use in sleep apnea as the primary indication. That doesn't mean people can get it for that. It's approved, but very few insurance companies pay for it for that indication. I wanted to comment about the Hollywood use. We call it Hollywood use. It brings up an ethical question. It's so hard for people who really need this medicine to get it. If you have a BMI of 25 and want to go to 22, or maybe if you're in India, you have a BMI of 23 and you want to go to 20, in my mind, it's not very responsible to use this drug up. And because you're using it, somebody with a BMI of 50 who really needs it to live can't get it. So I rather disapprove of that cosmetic use.
Yeah, I just want to know one thing. Our patients, they stop this drug. They do not continue because of two reasons. One is cost, and another is GI side effects are very common. How do you tackle GI side effects? Any take home?
Yeah, I'm intrigued. So I agree with you, many people stop them because of cost. I'm surprised you say that the GI side effects are that limiting. That's not the same as what I've experienced. I mentioned in my talk that I think the rate of discontinuation for side effects is less than 5%. I wonder if there's a difference in the susceptibility to GI side effects among South Asians versus Americans. The-
side effects are high in India.
Are you talking about injectables? Might it be that you're talking about oral semaglutide?
Yeah, we have more experience with the oral semaglutide.
Oh, so yeah, that's a vomit drug. Yeah, that's a totally different drug. The GI side effects are much worse with oral GLP-1 receptor agonists.
So I have something to comment on that, and when me and David we were discussing, I told him that that's the problem we face here in India. We have a lot of discontinuation with Saxenda, 3 milligram of liraglutide.
Yeah.
And David, I would like to comment on that. One of the reasons is we are primarily carbohydrate eaters. Carbohydrate eaters have more nausea. They are meat eaters and pork and beef eaters. They have less nausea. So there is a study on that origin of food and the type of food you consume. So in our case, we will not tolerate this drug the way it's being.
People could tolerate more than 1.8.
Yes. And about your question about the Bollywood thing, they are all off-label use. They should never have used it. They just used. They were first of all not good candidates for this drug. This drug should only be used above a BMI of 30. That too with comorbidities. So people are using. They're bringing it from Dubai and several. We gave.
They have a lot of
other
money, they
people
can do it.
ourselves, so it's.
You know, that's something I didn't know. People who are carbohydrate eaters are more prone to nausea?
Yes, I'll share papers with you. They have much more higher incidence of nausea, gallstones, peptic ulcer disease. There are 10 diseases.
Do we know
GI
why?
side effects, yes.
Why, do you know? Sorry, I'm a kind of a mechanisms guy.
The mechanism is not known, but they have a lot. Maybe the amount of satiety comes to you very early in your origin of people because of protein intake. We are hardly able to consume 0.5 gram per kg body weight of protein by the diets all of us have here in India. It's pure carbohydrate, very less protein. 0.25.
I'm aware of that, yeah.
Yes.
And we are being habituated to get full.
Yeah, yes.
The moment the food is not
Yeah,
over here, we are not satisfied.
So there is this publication, and I'll share. We will have more nausea and the highest rate of discontinuation. And I'm not talking about Ozempic or Mounjaro. They've just recently come. But liraglutide has been used by everybody in this hall.
So-
I was never able to use 3 milligram in my patients. Never. They
Yeah,
have,
well, liraglutide is not as good a drug as semaglutide or tirzepatide. So I wouldn't necessarily damn these newer drugs based on your experience with liraglutide. So it's a word of caution. Maybe in your patient group there'll be more side effects, but that hasn't been shown. It hasn't been documented yet. 3 milligrams liraglutide, Saxenda, that does cause more nausea than my experience with semaglutide or tirzepatide.
What is your experience regarding use of a prokinetic agent while starting this drug? Or something like ginger water?
I don't have any experience. Sorry, I would have to be commenting off without evidence. But I would say, Mohit wanted to know, what could we give to people who experience nausea with one of these? I'm not aware of any specific agents that will counteract the mechanism by which that nausea is caused. But I also don't see any reason why a standard antiemetic wouldn't work the same way it does with a GI illness. So in our country, that would probably be ondansetron. In your country, it's called?
no, so I've been using Mounjaro for last so many years now, Ozempic. We have a lot of nausea, we give apripitant. This does not work. Ondansetron does not work for nausea with patients with Ozempic. Or even we used to give apripitant, so apripitant has to be given for 3 days. First day, second day, and third day. And
Okay.
by the third day, the nausea goes drastically down with Ozempic. With Mounjaro, I'm still to test, not because it's just launched.
So Mohit has a kind of contrary view about the nausea likelihood of tirzepatide versus semaglutide. He thinks it's worse with tirzepatide.
It's
The
equal. It's
common-
best equal.
Use these prokinetics which he just mentioned.
Yeah,
like,
we have used, but they don't
glucophage or-
work. But they don't work. They have nausea. They still have nausea.
Because the gastric emptying is slowed by these drugs.
Yeah, I've been asking him. They have nausea. The gastric emptying is being promoted by the prokinetic to counteract
To counteract this
semaglutide.
end of slow.
But it doesn't work. Semaglutide is very strong. In fact, to be honest with you, we are not operating patients until we discontinue semaglutide for 2 weeks
Oh, yeah, well,
for risk of aspiration pneumonitis.
yeah, you shouldn't have any operation when you're on these drugs, because if your NPO after midnight, nothing eaten over midnight might not be enough to clear out the gut, so you can aspirate. For what it's worth, in the kind of common conversation, it's said that tirzepatide causes less nausea than semaglutide, contrary to what Mohit has experienced.
It's equal.
Okay.
I'm not seeing differences.
And that's just a rumor, but they say that the GIP component confers an anti-emenic effect. In this meeting, I've asked two of the other speakers to give me the data that support that, and nobody can. So I think it's a rumor at the moment, but Lilly is certainly selling it. So we'll see. Yes, sir.
So you said a positive effect in terms of incidence of osteoarthritis. Now,
Yeah.
is it due to loss of weight?
Yes.
Or there is some metabolic effect to reduce it?
As far as I know, it's just because you have less weight to carry around. It's like you don't suffer so much from your bad knee when you go through bariatric surgery because you've got less weight every time you walk across the floor. Now, that said, some papers show an anti-inflammatory effect of GLP-1 receptor agonists. So conceptually, there may be a direct effect, but I don't think that's been proven yet. What's more clear is that if you have bad joints, it's easier to carry your less weight on those joints. The New England Journal paper that I quoted, which showed reduction in symptomatic osteoarthritis, it didn't say that the arthritis looked better on x-rays or anything like that. It was just that the patients suffered less after they went on the drug.
Can you combine with the Orlistat?
Can you combine with Orlistat? Sure. I mean, you can if you like Orlistat. You can combine them with any weight loss drug around. They work by different mechanisms, so they should be complementary. So they could go with Orlistat, phentermine, Qsymia, Contrave. Those are the approved drugs I know of. I personally wouldn't consider Orlistat a very high priority drug because it sort of makes you feel like shit, but to use vernacular. I think Orlistat works by causing side effects. And people learn that if they eat a high-fat meal after Orlistat, they're going to feel terrible. And so they behave their way away from high-fat meals. And its effect is only about 3 to 4% body weight loss. So among the various other medicines that I consider Orlistat the worst, most side effect pronounced, least effective. That said, there's no reason you couldn't combine it with GLP-1 or phentermine or Qsymia or Contrave.
It was just a question few days back. A lady has already implanted one balloon, gastric balloon. Now she wants to take this drug.
Yeah, that's something we're thinking of testing in indoor. Theoretically, it should be a good combination. It has not yet been tested. But because the balloon works through gastric distension, sending neural signals through both spinal and vagal afferent nerves to the hindbrain, that's their mechanism of satiety. And GLP-1 works through humoral mechanisms acting in different brain centers. In theory, they should be complementary mechanisms that should have additive effects. And in addition, by the way, a balloon plus phentermine should be even more additive because they're really different. One of them is an energy expenditure, the other one on food intake. So theoretically, a balloon in combination with some of these meds should have additive effects. But that has to be tested in a randomized trial. So the trial would be balloon plus placebo versus balloon plus drug. Those are on the sort of drawing board right now.
Yeah, this is approved in India for non-diabetic obese patient.
What was the question?
Approval regarding it's in non-diabetic patients. Yeah, it is approved.
In India, it is approved on
I think it's just barely become improved.
It is for diabetes and obesity, or it is for
Non-diabetic
obese
patient.
I ask you guys what.
the CDSCO has given approval for anybody above a BMI of 30 with comorbidities, without comorbidities above 35.
Oh, is that it?
So your question, non-diabetic only above a BMI of 35.
Yeah, definitely.
So everybody else who is using it in the hall is off-label.
Oh, by the way, in my country,
If you are a non-diabetic obese, you can use it only if you are above a BMI of 35. That's what CDSCO says, DGCI approval.
That's interesting, Mohit.
Yes.
So your BMI threshold for approval is higher than ours, even though you folks tend to.
It's always been higher, David. In India, they think that never had obesity as a major problem. We are still a diabetic nation.
I know, in theory, your threshold should be lower because you get sicker with lower
I'm
BMIs.
saying what Cedesco says. I have read the approval, and it cannot be prescribed by surgeons like us. Only by physicians.
In Europe and North America, it's approved for BMI over 30 without complications or 27 with complications. But in this country, it's,
With comorbidities.
that's correct.
And
Pre-diabetic, you can give, but it's like again.
He's obese greater than 35 BMI.
35 BMI. Yeah.
And how safe is this drug for maybe for breastfeeding lady or persons who are planning for pregnancy?
No date.
No data.
It's not approved for pregnancy. That is not because there is any known teratogenic effect. It's just unstudied. So by way of caution, the company wants to stay away from pregnant ladies. I have no reason to believe it would cause birth defects because it only mimics a natural hormone your body sees all the time anyway. But it has not been tested against in pregnant women, probably won't be for a long time. So for the better part of caution, it's contraindicated in pregnancy. I don't think it's spoken about with lactation, but I see no reason why it shouldn't be okay in lactation.
We come across a lot of patients, PCO patients, so we give them GnRH analogs. So can these drugs be given with those drugs? We come across a lot of PCO patients with a BMI of more than 30, 35, so they want to become pregnant. So we are giving, usually gynecologists are giving metformin. Should we give these drugs with GnRH analogs, which we give for ovulation induction?
Well, the drugs are okay for the treatment of PCOS to help with the weight loss. That would help that. If the person is really trying to get pregnant, I think you're in kind of dicey territory. You either should stop that while they're trying to get pregnant, or at least be really careful that they stop it as soon as they know they're pregnant. But because, sometimes people are pregnant for a while before you know it, and because birth defects tend to be worse in the first trimester, as a physician, I'd be inclined to, if somebody's actively trying to get pregnant, I'd probably take them off of GLP-1s. It's just, if you had some problem and the woman sued you, you wouldn't be able to defend yourself very well.
We have got so many patients with MSLD also.
MASLD?
Non-alcoholic fatty liver disease.
Yeah.
Liver disease.
Yeah, MASLD.
So MASLD, we have got so many patients. So what is your take of this molecule on MSLD?
Yeah, so that was involved in the one New England Journal paper I quoted, looking at major adverse liver events. The mechanism by which it improves those is undoubtedly because it helps with non-alcoholic fatty liver disease. So they're good drugs for that. Some of the ones coming through the pipeline are probably going to be even better. And retatrutide is sort of like Mounjaro plus one other agent. The glucagon stimulation from that should be especially good for MASLD. In the body, glucagon's job is to mobilize fuel sources from available stores. That's mostly in the liver. And although we may know as endocrinologists this is a counter-regulatory response to mobilize carbohydrate stores, it also mobilizes lipid stores. So that would help you clear out liver fat. So in answer to your question, these drugs should be good for MASLD. The new ones that are going to add a glucagon receptor agonist are probably going to be even better.
Recently, there are some papers on Alzheimer's disease also.
Yeah.
GLP expression in brain, and now it is stopping the onset of, or it is delaying the onset of Alzheimer's disease.
Yeah, well, I pointed that out. That was found as a possibility in the Nature Medicine paper that looked at just diseases that were less common among people with GLP-1s, and Alzheimer's was one. And then in the meta-analysis of all randomized trials yet done with GLP-1s, they found that people randomly allocated to GLP-1 had fewer indices of all-cause dementia. It wasn't, I don't think it was statistically significant for Alzheimer's per se, or for what they call multi-infarct dementia. But if you put all the various causes together, the GLP-1 group it was associated with fewer dementia indices.
It's good for India because we have got multi-infarct dementia. It is very common in India.
Well, you would expect it to improve that because with weight loss and improved cardiovascular events, one of those cardiovascular events is mini strokes.
Yeah.
So that's no surprise.
I'm Dr. Chavala, I'm a gastroenterologist here.
Hi there.
So we have a lot of it. I think the concept for managing now this MSLD actually is changing in the sense people are now more focused toward changing the metabolic milieu of these patients because that helps in both ways. If you have an obesity, you have diabetes, along with that fatty liver, if you change the entire metabolic milieu, definitely it is going to help fatty liver also, and that has been proved in studies. So you have now a lot of papers which are coming in where they are saying that GLP-1 analogs, a combination of them, like they may be single, they may be dual, or even a triple combinations are now being tried in managing both the things, or all these three things together. So you have an effect on diabetes, your obesity, that also comes down, and at the same time, as a surrogate, this thing, your fatty liver also improves in that particular situation. Majority of the effects of GLP-1 analogs as far as fatty liver is concerned is all extrahepatic. There are no GLP-1 receptors in the liver. If you have glucagon receptors, it's okay. So mainly it's extrahepatic. That means you change the metabolic milieu. If the patient comes to you with diabetes and all this thing, he has fatty liver, he has not developed fibrosis as yet, these drugs are going to act wonderfully because it will correct the entire pathology which is there in this patient. As far as fibrosis is concerned, there is no remarkable effect on fibrosis with these particular agents. Although some studies have shown that there may be some regression on fibrosis, but the hard data which are required actually to say that they are really effective, the fibrosis is not much affected. So the new concept is now coming in. You have one additional FDA approved drug which got an accelerated FDA approval in, I think, March 2024. That was resmetirom, which basically acts on a thyroid it's a beta receptor agonist, liver-specific thyroid receptor. There definitely they have found that there is definitely one-stage regression of fibrosis without influencing any steatohepatitis over there or without worsening the steatohepatitis. So this drug has got an approval. So people say that an extrahepatic effects of GLP-1 analogs, either single, dual, or triple, in combination of resmetirom will probably work much better in those patients who have got MSLD and the serious form of MSLD like MASH or definite fibrosis that's there.
So I agree with what you say. The effects of GLP-1 to help with MASLD, as far as we know, would not be any direct benefits on the liver. They're just the indirect benefits of weight loss and improved diabetes. Whereas resmetirom, is that how you pronounce it? The thyroid receptor beta agonist may have direct impact. There's been no direct comparative trials of GLP-1s versus that. In my institution, we're just getting started on a real-world experiment in the national VA system to look at people and their impacts on MASLD of resmetirom versus GLP-1 receptors versus other things. I would like to point out in terms of MASLD, no drugs yet approved are really great, really powerful. What is bariatric surgery. So the older study is called the Splendor trial. It was a trial in the United States done by Ali Amini, and a first-class scientist. He looked at liver biopsies throughout the United States that were done biopsy-proven fibrosis, and then asked what happened to people who had bariatric surgery compared to those who didn't. Those who had surgery with biopsy-proven fibrosis and no cirrhosis had an 88% reduction in major adverse liver events like liver transplant and cirrhosis. And then in the recent study just published a couple months ago called Special, that was in Nature Medicine, the same kind of a design, but it was people with biopsy-proven cirrhosis compensated, so F1, 2, or 3, or 4. Those people had a 72% reduction in major adverse cardiovascular events if they happened to undergo metabolic surgery. Bottom line, metabolic bariatric surgery is by far the most effective technique we yet know for treating MASLD either with fibrosis or with early cirrhosis.
In India, the phenotype is like lean fat Indians. So we have MASLD even in those who do not have that much of BMI, which renders them for bariatric surgery.
Okay. Yeah.
Lean fat.
You know, one of the other things about Indians that I've picked up on this trip is that I remember in a prior trip that when I went to the Asian Institute of Gastroenterology in Hyderabad, there's a huge unit there for pancreatitis, just for pancreatitis. So in my country, pancreatitis is pretty rare. You get it in people who drink a lot gallstones, maybe super high triglycerides. But apparently you guys get it out of the blue, like just pancreatitis. And so since pancreatitis is a theoretical concern with GLP-1 receptor agonists, I do wonder if that's going to be a bigger problem in your population than in ours. That's unknown territory.
Thank you. Thanks a lot.
Are we closing up? I have one request. I would like to take a picture of you. Okay? So just sit there. I'm gonna get out of this light.
It's like going in a reverse gear.
Okay. Photography is my main hobby, apart from
So, David, I'll take
history.
stand in between the
Yeah.
photos. I'll
Yeah,
take a
please.
picture.
Okay, come on back here. Stand far back.
Mohit, you can come here. Yeah.
Although if I'm in the thing, it doesn't look like I'm talking. But okay, do one with and one without.
So many pictures with you.
Okay, I'll sit next to Satya. Let's do one with and one without. Try to include everybody. Okay, now I'm going to leave. And I'm turning around. Satya, you sit down. And you too.
Mohit, Tata.
Thank you, everybody. And servers, could you get out of the way of people? Thank you.
Yeah.
All right, now look at the camera. I mean, look at the screen. Bye-bye. Thank you. Thank you for your insightful questions. Very knowledgeable questions, everybody.
It was a very enlightening lecture. We are thrilled to have you over here. And there are so many questions, I think, which are not going to end. So we'll keep on discussing and asking you those questions in between.
Yeah, I'm happy to stay.
So now this is an opportunity in India. Whenever we do a pious activity like this, academics, so we inaugurate and we usually go for the lighting of the lamp.
Yes.
That is Saraswati Pujan.
A lovely
So
tradition.
I invite Dr. Shashi ma'am, Dr. Rachna Dubey ma'am, Dr. C.C. Chaubal sir, and please come for the lighting.
Thank you. Are you going to record this? Are you going to do this with the video? Can I give you my camera? Maybe you have a chance? Okay. But do your own thing first. Okay. Well, I'm more interested in the still photographs. Let me take this.
सामने भी मैं देख रहा हूँ मैं समझ गया मैं कंफ्यूज हो रहा था भाई ये आपको हॉस्पिटल दिखाता हूँ So back to back we have got two stalwarts, so I invite Dr. Mohit Bhandari. He'll be talking about the future of surgery for obesity treatment in GLP-1 era. There are lots of things which may come up. So I think Mohit is the right person who can answer us with the battery of questions which is being expected. So Dr. Mohit Bhandari, the stage is yours.
Thank you, Dr. Sachin. I think this is one question I get very often from not only physicians but surgeons also, that now since there are so many drugs, what will happen to the role of bariatric metabolic surgery? And do you think that surgery would become obsolete and things like that? I'm a surgeon, I'm not a physician. This is the institute where I work. We have a dedicated bariatric metabolic surgery hospital, one of the only hospitals which is just dedicated to this specialty. These are my disclosures. I should be honest with you that I am a consultant to both Eli Lilly and Novo Nordisk, responsible for bringing Ozempic and Mounjaro to the country. And these disclosures are very important. I hope you can read them. I was involved in the clinical trials for Sedesco, DGCI for bringing semaglutide, both oral and injectable. I was also involved, I'm still involved in the trial of cagrilinotide plus semaglutide, which is known as CagriSema. And I'm also involved in trials for safety profile of tirpazetide in India by Sedesco. And they pay me as a principal investigator to bring this drug to India, apart from several other things. You should know about it. Whatever I speak, I leave it to your wisdom to judge my lecture in the light of this disclosure. But this is interesting disclosure. I have performed 31,000 bariatric procedure, close to this figure. This is from January 2010 till until 2025, January. You can see that I've done pretty much the largest number of gastric bypasses in probably whole Asia Pacific region. This is another disclosure. We are one of the largest training center, and this is the IRCAD training center, which is in Strasbourg. We brought it to India. The person in the center is Professor Jack Marescau. He's one of the pioneers in robotic surgery and training the world into robotic surgery, and that center is in India. This is Professor Manuel. So as Professor Cummings said, that I have three things to treat obesity. The first is the surgery, the second is the endoscopy, and the third is the drug. So we just completed the circle, both Professor Cummings and Manuel will be in India. I would not say every other month. Manuel is here every other month, but Dr. Cummings will be here every 2 months. So you will get to know him more and we'll learn much more. So I'm one surgeon who is not obsessed with the science of surgery. I am not obsessed with the art of surgery either. I am just obsessed with what is the evidence. And I believe in the collaborative effort, like David said. We are not here to say this is best, this is better. We have one of the most famous gastroenterologists, Dr. Chaubal, sitting here in the crowd. I have learned endoscopy in 2015 after doing 20,000 bariatric procedures. And why I learned endoscopy? Because I realized that you cannot do bariatric surgery without learning endoscopy and the endoscopic skills. So we have completed the circle, and now what is the future? When you have Ozempic and Mounjaro being tried by every other person on this earth. So let me tell you very honestly, and this is not philosophical, this is very scientific. Obesity is the most chronic disease on this earth. So it is just like cancer. No matter how you treat obesity, whether you choose surgery or you choose drugs or you choose endoscopy, you can at best ameliorate the disease. You can never treat it. It's like cancer. You will never be able to treat it. I have a patient I did gastric bypass on, one of my first gastric bypasses, when Dr. Phoebe used to guide me, and I don't know, there are surgeons here who've heard about the Phoebe Capella pouch, the gastric bypass operation. So I was trained by him, and he used to guide me way back in 2009 and 10. He was an open surgeon, but he trained me to do laparoscopic gastric bypass. That patient has gained 70% of his weight. So please don't get too excited about these drugs. I know the whole story. I know the story of all 30,000 patients I have operated. Let's not get excited. Let's try and help each other, because obesity is a very, very chronic disease. It's very chronic disease, and please do not say that monotherapy is going to work in obesity. By the time all your excitement is going to end, you will see the patients coming back even with non-responders of weight regain after Ozempic and Mounjaro. We had a big OPD and a lot of VIP patients came to see David on the day at Mumbai, at Sahara Star Hotel. A lot of them, some of them we cannot even name here. David met with one of the most richest person in Mumbai. He is taking Mounjaro for last, David, I think 3 to 4 months. Did not lost even a single kilo.
That's true.
So 12.5 a week, 12.5 milligram. We don't even have that dose available. He was getting the drug through me. I've been supplying him this drug, and he's a very good patient, by the way. Never see, people at that position, they have this habit of showing us down. But I said, David is coming, please meet him. I'm sorry, this drug has not worked on you. And what David said to him was so humbling. He said, yes, it can happen. We have a 20% non-responder rate. 10 to 20%. So that's what. So we have to look beyond surgery. This is very important. Obesity is more chronic than cancer. And my entire lecture will be based on this premise because this is the reality. When we used to treat cancers, we used to give neoadjuvant chemotherapy. Then we downstage the disease. We do the surgery. And then, sometime later in the life, the cancer might recur. And we either give radiotherapy or do another surgery. So we have a tumor board. In a similar way, now we will have to have an obesity board. And believe me, every center should have that. Even if you are not practicing surgery and you are just, say for example, Her Health, they should have an obesity board because obesity is going to touch every specialty. You may be a gynecologist or an orthopedician, pulmonologist, dermatologist, radiologist. Obesity will touch you. India is growing in huge numbers. So obesity is growing in huge numbers in India. So we need to have an obesity board which would decide what treatment is the best. So I will discuss all these treatments with you, lifestyle and behavioral interventions, very, very important, pharmacological treatments. I'm going to talk in a very different direction than what David had talked about, something very interesting for Indian audience, endoscopic techniques, minimally invasive techniques, innovations in obesity, emerging therapies and combination therapies. Somebody asked the question about combining a drug with a balloon. Now, I don't know how many psychologists in India are trained to treat patients of obesity. I sent my psychologist to US for 6 months to get trained in cognitive behavioral therapy, trained in mindful eating. It's very difficult. It's a completely different training. Exercise programs and dietary approaches. We are starting this year on this kind of program to train the psychologists. So if you have a psychologist, we'll do a 1-week course to train them into this. But this is the first approach. Every bariatric patient or every patient who even needs to go on a drug will have to go through this therapy. Insurance is going to mandate it at least for bariatric surgery in India, even for endoscopic therapies like endoscopic sleeve gastroplasty, but this is something which has to be the first approach before the patient with obesity needs to be treated, because believe me, out of 100 patients I do surgery a month, now there are 150 a month, 70% have some or the other underlying psychiatric illness. And it goes undiagnosed. And please do it because that has medico-legal impact on your practice. Treating obesity just like prescribing a drug, opening a shop is not going to help. We need a psychologist. We need a clearance from a psychiatrist before we offer even Mounjaro or Ozempic, because no matter what we say in our country especially, we will have patients who will have suicidal tendencies or several other psychiatric disorders which will not come into notice of the practitioners. And they would go hidden. Patient will hide the history because we don't have time. If a patient of obesity comes, we cannot give 40 minutes to that patient. If we are sitting as a gynecologist to treat PCOD, you cannot give 40 minutes. It's not practical. But if you really want to touch obesity, have a psychologist. I am ready to train and give them certification, 1-week program, so that they know what kind of patients we are dealing with. Now this pharmacotherapy, the second approach, which we are going to talk about. So we have phentermine topiramate, which is known as Qsimia. Physicians know about this drug, but gynecologists should also know about this drug. It's not available freely in India, but available in my practice. It's a very cheap drug, 10 rupees for a week. You can procure it through me. You can also get it through the patient appeal process. Very good drug. Professor Cummings will tell you that he uses that drug in a huge way in his practice at his hospital. It's a cheap drug, readily available. So you can get it for your PCOD patients, it has no contraindications. And last year, Professor Manjul Mahashabde, she is a gynecologist from Indore. She came in to deliver a lecture at Indore Obesity Society conference, and she trained gynecologists about the use of phentermine in their PCOD practice. But this drug is available in my practice. You can get it through me. Orlistat, we all know it's a very old drug, but semaglutide, tirpazetide, and now retatrutide, these are the new drugs which have come. They have different mechanism of action. This is the news from what Bollywood has been showing. It's secretly reshaping the waistline in India. 50% of Bollywood stars who are taking this drug is off-label. It's not recommended. They do not have that kind of weight where they qualify for taking these drugs. They are just taking because this trend is coming from US and Europe, where the drugs are coming from either Dubai or several other Middle East countries at a very high rate, and they procure it through them, not through companies. I don't know whether these drugs are really spurious or they are really good drugs from the companies, but most of them are good, and they are taking it, and that's why you see a lot of side effects like Ozempic facies, muscle loss, and several other things which is highlighted on social media. Now imagine if an actor and director who is very famous is shown to have taken Ozempic and lost weight. Imagine if I do his bariatric surgery. He will have Ozempic facies. Anytime you lose more than 20% of total body weight, you lose lean mass. I mean, why there is so much of noise about lean mass loss with tirpazetide and semaglutide? We have done bariatric surgeries. Our patients lose muscle mass. They look like Ozempic facies. It's very common. I don't know why there is so much of noise now. I have done duodenal switch. They were super obese patients. They lose a lot of muscle. They lose a lot of fat from face, and then they have a lot of hanging skins. In fact, out of 150 procedures I do 50 others which are post-bariatric body contouring. So why are we just blaming it to Ozempic, Mounjaro? Anytime you lose more than 20% of total body weight, you will always have muscle mass, you will always have a lot of hanging skin, you will always have a lot of problems with your face. It's not with the drug, it's not with, you have to take cosmetic, plastic, bariatric treatment for that, because you have that. And for those in Bollywood who are taking it, they are taking it off label. Nobody, they have no prescription. It's from the black market, and they use it at the highest dose first of all, have nausea, vomiting, and then they reduce the dose. So there is no physician actually guiding them. Most of them are dietitians. There are famous dietitians in Mumbai, they are guiding, there are no physicians prescribing them. We had this meeting in Mumbai with David 2 days back. Most of the physicians we had a talk with, they have never prescribed this drug to any Bollywood star. Now, if you see this, there is a big gap between these drugs and bariatric surgery. And so what David said, bariatric surgery still remains the most powerful treatment to treat obesity and metabolic syndrome. But what is the new procedure? So let's talk about the endoscopy. There is in endoscopy a procedure known as endoscopic sleeve gastroplasty, where you put a scope through the mouth and take sutures inside the stomach and reduce the capacity of the stomach. I was amongst the first one with Amit Medev and Rakesh Kalpla to start this procedure in India. We have been using it as primary therapy. Patient comes in the morning, we put a scope inside the mouth, just like any endoscopy, take sutures inside the stomach and discharge the patient in the evening. It's a very good procedure, and you can see that this is the instrument which we use. This is a double lumen scope, and this is the Apollo overstitch device, now taken up by Boston Scientific. And this device can take sutures inside the stomach, and what you see is something like that. So you can see this is the gastrographin study done immediately first post-op day, and you see how thin the stomach looks like. It's like a tube. So I've been training gastroenterologists all across the country to do this procedure. It's a little difficult procedure in terms of putting a scope and taking sutures inside, but we have done 3,000 of them now. We are a training center for that, so anybody interested in learning it can come. This is the first data published by us, the first Indian experience of endoscopic sleeve gastroplasty. At 4 months, we have 17% of total weight loss, which means that if a person of 100 kilos, at 4 months, he lost 17 kilos. Again, people complained that ये जो sutures आपने अंदर लिए टूट जाएंगे, they'll break with over a period of time. So this is a 4 years data published by us only. These sutures remain intact. You have to do an endoscopy and check they remain intact. and the patients have maintained the weight over 4 years. It's just the technique which has a very steep learning curve for gastroenterologists. We have trained 500 of them in the country, only 5 or 6 of them are actually actively practicing this procedure. It's a little tough procedure. A simpler procedure now I am doing is known as the POSE, primary obesity endoluminal surgery. It's very simple. Here, it's cheaper. You have a pediatric scope going inside the mouth. So you can see we have a pediatric scope going inside. This is the stomach. And these are more full thickness bites as compared to the endoscopic sleeve. And this is a reusable device. So it's pretty cheap and less of a learning curve as compared to the endoscopic sleeve gastroplasty. This device will soon be approved in India and will be available at most of the gastroenterology center. It comes by a company known as USGI. But you see how thick these, the tissue you can take, the deep bites you can take, and you can reduce the capacity of the stomach. Again, it's time when gastroenterologists are going to take over surgery because now we have magnets. Gastroenterologist can take help of a surgeon, put magnets in 2 parts of the bowel, and you can see how beautifully this anastomosis can be done. This is a gastrojejunostomy. You can see it just took 15 seconds. 1 magnet in the stomach, 1 magnet in the bowel, combine them and it's done. You need no skill. So gastroenterologists will enter into the arena of surgeons, put magnets, and then they will do endoscopic sleeve and sort of narrow the stomach. So what gastric bypass we learned by doing laparoscopic technique, now gastroenterologists are going to do 2 magnets. They will combine it. A surgeon can come, it's take 5 minutes, and then they can go inside a scope and make small pouch out of the stomach. So this is the ESG plus magnet. This procedure is going to be there. Again, for gynecologists and physicians who do not want to learn endoscopy, this is something very good, available now in India. We have been doing it last 3 years now. I was one of the principal investigators to introduce Allurion. It was also in my disclosures. I forgot to specifically mention it. And I brought swallow balloon Allurion to India. No surgery, no endoscopy, no anesthesia. So during the time of COVID, I was lying on the bed without any surgery. The government banned all the surgeries, and patients who were obese were coming to us saying, sir, do something where there is no surgery, no anesthesia, no endoscopy. And we came up with the revolutionary Allurion balloon. So what is it? You can see here, patient enters inside the hospital. So this is a patient. He will enter inside the hospital. So he will come, and you just require a room like this with either an X-ray machine or a Siam. And then we will explain the patient how he has to swallow the capsule. It's like any other tablet you take for pain. So you have a pain, you take a tablet, it's like that tablet. It has a small thread attached to it through which the filling of the capsule, which has a balloon inside, is done. So you can see that's the capsule. It's like B-capsule, B-complex capsule. It's a little larger than that, but very, very soft, more softer. And then I place it on the posterior wall of the mouth of the patient, and patient can drink either Coke or juice or liquids, whatever he wants. And then we take an X-ray. Now there are new kind of capsules where you don't even require that, but this is the older version. You take an X-ray, check the position, and then you fill this capsule, which has a balloon inside, with 550 ml of fluid. So you can see I am filling the capsule, and it's pretty simple. Once that is filled, you take another X-ray, and you show the patient that, okay, your balloon has filled properly, it's in the right place. And then once that is being done, you can remove this catheter from the mouth of the patient, and that's it. And this is the procedure. It takes 5 to 7 minutes. Outpatient procedure. You can have this balloon in your clinic, and it causes good amount of weight loss. We have been doing it on families together. So you can see this is a family, brother, wife, wife's brother. And then I did it to all of them, and 5 minutes they go home. The good thing is they lose good amount of weight, 10 to 15 kilos in 4 months, and they get back to us. So this is good. This is another one. When I do courses, I do on 30 to 40 patients together. So these are 40 patients lined up together. We put them all in a big hall. We have an X-ray radiology facility there. We keep on giving them the capsule one after the other, and you can do so. This has to be there on all gynec clinics who deal with PCOD. You already heard that GLP-1s cannot be given to PCOD because of the problem. You do not know if they are teratogens or what. But this is easy. This is simple. Anybody can do it. In Europe, most of these are being done by either gynecologists who deal with IVF infertility patients for PCOD, or they are done by orthopedicians who cannot do a joint replacement because patient is overweight. Also being used by a lot of pulmonologists to treat patients with obesity. So this is interesting. We published this in patients with type 2 diabetes, and type 2 diabetes got better. And so, what is the future? So combination therapy. Somebody was asking, can you combine a drug with a balloon? Say give balloon and then give Mounjaro to the patient. Absolutely fantastic idea. It's not new, first of all. There have been randomized control trial where endoscopic procedures were combined with semaglutide. And they have given, again, another trial. But this is something which I did. And this I can tell you because this is published trial which I performed. Effect of swallow balloon therapy with combination of oral semaglutide, a randomized, double-blind, single-center study. This is what we published with Manuel Galvao. And David, I don't think, David, you read this article. I think you missed the article because this is the article where it's a double-blind trial where we had two groups. One where we did balloon and we gave a placebo, like a drug, oral drug. He did not know whether it's semaglutide or not. The other we gave balloon with Rybelsus. And we combine, and you see this is fascinating results. We have a difference of 7% total weight loss between the two groups. So this is already there. And the balloons are cheap. And the drug Mounjaro, the way it is launched in India, is also cheap. It's not very costly. Bariatric is costlier. But you see what is the good thing here. The weight loss is 17% total weight loss. That's what you're going to get at the end of the day. There is very good resolution of dyslipidemias in both the groups. And so this is the combination therapy can be the future. Again, this is our own published data, endoscopic sleeve alone and endoscopic sleeve with semaglutide. Again, you see the difference in weight loss. 17.4% with the endoscopic sleeve alone and 23.2% with combination. So gastroenterologists in this hall should be really excited because 23.2% with endoscopic sleeve at 2 years. This is a published data. It's fascinating. I mean, when we have seen such kind of results, apart from bariatric surgery, we have never seen. So combination is going to be the future. If you have learned the technique of endoscopic sleeve, if you have the accessibility to a swallow balloon, give the swallow balloon to the patient, he can go back home, start semaglutide injectable or oral, whatever you can in a protocol-based fashion, and you will see. And similarly, when we have weight regains after bariatric surgery, all these patients are put on GLP-1 analogs. I said that the gastric bypass patient I did 20 years back is now coming with weight regain, and we give them injectable preparations which are available now. So I think there are challenges. I agree, everything is not hunky-dory. We have cost, we have patient adherence, we have limited data and limited access. But I can tell you this very honestly, that in long term, if you combine the two approach, endoscopy with GLP-1 analogs, in long term, due to reduced obesity related complications, it is going to make a lot of savings. And in India, insurance is reimbursing both bariatric surgery and endoscopic therapies like balloon and endoscopic sleeve gastroplasty. So I think it's a very exciting time. What is the future? The future would be personalized obesity management models. Already we have Professor Lee Kaplan working on a blood test which can be taken from the finger, and that will decide what is the best for the patient. Now, how that would work, I think David can throw more light. I don't know into the research, but they're trying to go at the level of the genes, trying to assess whether the surgery will work the best for this patient or endoscopy or a drug, and what is going to be the future 20 years for this obese patient. So that's going to be the future. We will have personalized obesity management models. We will have a combination of drug and endoscopy. It's already there. And we will shift towards the maintenance therapy model. See, it's very important. As surgeons, I have realized what looks good at 5 years can be extremely bad at 10 years. It's just like marriage, you know. You go on a honeymoon with a girl, and then 10 years later, you might end up with a divorce. So it's like marriage every other day. It's not becoming better like a wine. So you have to continuously act, see what is going to be the future integration model, and maybe I think digital health and patient-centric outcomes will be the key. I don't know if there are physicians here who are dealing with obesity. I think Dr. Sachin does. There are others also. But how many of you, when you give a drug for obesity, give a weighing machine to your patient? Anybody? I give weighing machine, I give weighing machine to all my patients, and we have an app where the patient would register his weight every day. Otherwise, we do not call him for a follow-up. If the data is not with you, you will be fooled by companies, corporates, or maybe surgeons like me, because we are advising so many companies. We can obviously be governed by the opinions with the conflict of interest. So I think you should be having a surveillance program on digital app where you make a obesity app and the patient, because a weighing machine for a patient with digital platform will cost how many? 1,000 rupees, 1,000, 1,500 rupees if you buy in bulk. And if you give that and make your app, making an app of the center is just a one-time job. It is going to give so much of data that you would realize that this is going to be there. Gut microbiome, gene therapy, and digital health, they are there. We will be talking about fecal cell transplant maybe in the next lecture. I know the gastroenterologists get very excited about that. But this is this slide you can take a picture of. This is very important. People ask, sir, ab kya karna hai? So between a BMI of 27 to 35, I think anti-obesity medications will take away this area from surgeons. This will be with 27 to 35 will remain with the physicians. And that's a huge, huge opportunity because these patients will never do surgery now. And one of the important reasons why they would not do surgery, because insurance does not reimburse at this BMI. This will go to the physicians and tons of patients. So there is no competition here. These patients are any which ways were not coming to surgeons. 35 to 40, hesitant about surgery. Again, all this will go away. This is going to go away. In fact, this is 35 to 40 is hesitant for surgery. Is that group of patient, they were not going to anybody. Now they will be seeking care. So they enter into the funnel of obesity treatment. BMI above 40, I think bariatric metabolic surgery, absolutely no question asked. I have treated patients with Ozempic and Mounjaro over 2 years when these drugs were not launched with clinical trials and away from clinical trials. So I know post-bariatric weight regain, again, big area of revisional surgery will move away from us. It will go to endoscopist because they can put in a scope inside and take bites on the outlet of a gastric bypass or suture the sleeve and discharge the patient in 2 hours. It will go away from us. Nobody is ready to do a duodenal switch, convert gastric sleeves to a duodenal switch now. It will also go to the endocrinologist. And those who are ineligible for surgery, high risk also goes to the this. In short, I always remember that this is what David told me, that we will be operating more sicker patients, more heavier patients, more poorer patients, and more older patients as a bariatric surgeon. So this model is going to take that course. Now, can we use Ozempic or Mounjaro for different reasons? Like everybody in the hall wants to use them for some weight loss. थोड़ा पतला 5 किलो ही lose करना है. उसके लिए क्या use कर सकता हूँ? I know David would say a big no, but I will share, again, this is not published data. You can take it as my opinion, you can criticize me, but I'm just giving you what we are trying to do and we are trying to collect data. So this is the microdosing of tirzepatide, which all of you are interested in. Appetite control in mild overweight or high risk individuals. Most of us would fall, 25 to 30. Everybody here would be a BMI of 25. Just want to lose weight for marriage and you are not yet candidate for therapeutic doses. What you would do, either you would progress to obesity or you can do a Mounjaro or a Ozempic. But there is a trick to it. The trick lies in the dose. So I start 1 milligram of Mounjaro and we keep it to 1 milligram. In India, we are lucky we have vials. If you do not have vials, I have a technique how from the injectors you can take just 1 milligram. If all of us start to take 1 milligram Mounjaro weekly, believe me, if we continue it for 2 months, let's meet 2 months later again in the same hall. All of us would have improved our parameters in terms of lipids, blood pressure, overall respiration, sleep by at least 10 to 20%, and we would have lost 5 to 8% of our total body weight. Just 2 months, I am telling you. So this is microdosing. Insulin sensitivity issues in pre-diabetics. 1 milligram of Mounjaro, it's a very good dose. Combination with other weight loss modalities, like they already said, balloon with a drug or ESG with a drug, microdosing. So this is what is there. If you are using Ozempic, you start somewhere from 0.25 milligram and then go every other day. So Monjaro 1 milligram, Ozempic 0.25 milligram, microdose once or twice a week for 2 to 3 weeks to break the cycle of binge eating or night cravings. And non-obese athletes or celebrities, they are misusing this to optimize body composition, but it is not recommended in them. So in short, the take-home message is we have to think beyond surgery. It's time. Surgery is not everything. We have to think about combination strategies. We have to think about monitoring our patients by digital way so that we know what the real-time data is. And at the same time, obesity treatment is evolving every day. There is so much to seek and so much less we know. Let's not get so excited about something which is coming on the block. And this is the slide I always play. This is beautiful. When I posted this slide on the obesity surgical group, they had whiskey in the night. They all celebrated because this is good to see. And David, you are such a nice person. Thank you so much. I know with the launch of Rita 2 Tried, you might change this slide, but this will circulate in the groups and it will keep motivating us. So thank you so much, everybody, for this patient listening. And if there are any questions, I'm more than happy to answer.
Thank you, Mohit. Thanks a lot. It was a very entertaining lecture. Now the house is open for questions. Sir.
Yes.
Cost of that balloon surgery,
Balloon procedure, it's around 1.5 lakh rupees. 1 to 1.5. Now it's covered by insurance, so most patients they get insurance completely reimbursed.
How long will you take to bring in Endozip in your setup?
Sir, mostly next month. We are already in touch with the Endozip guys. The problem in India is that CDSCO does not approve these devices very easily, even though there is a predicate. So we have to get the device to India, get the custom approval, and then design a study. Fortunately, with SAMES being in place, the ethical committee favorable to us, we are able to get these studies. Like magnets, we now got them commercially approved in India for gastroenterologists. Similarly, we will get the Endozip also. It takes a little bit of time.
So the gold standard for the obesity surgery has always been the gastric bypass.
Gastric bypass.
Now if you compare the number of surgeries, I think almost 60 to 70% surgeries are either sleeve gastrectomies or ESGs now.
Yes.
So what is the reason? Is it the complications related to this thing? Why?
Just market dynamics. You require less cartridges to do a sleeve procedure. So you want to I'm really sorry to say, but the honest answer is market dynamics. And with the insurance coming in, you will see more and more sleeves happening.
Cost of capsule.
Yeah, I said 1 to 1.5 lakh rupees.
So costly, and whether it's just a capsule only.
It's not just a capsule. If you see the device, it's a very sophisticated device. For us to ask a patient to swallow it and it gets filled and then you have to remove, you cannot have failures. So, yeah, and they have a monopoly. This company has a monopoly. They can't. Yes.
How long does it last?
4 to 6 months.
4 to 6 months.
It passes in motions automatically.
Is it the same thing that we talk about, the so-called hydrogel capsules?
No. Hydrogel capsules, you have to take multiple and they create a cellulose kind of, no, it's not the same. It's like an intragastric balloon. Like you put an intragastric balloon, but it's the same. It's just that you do not require an endoscopy to put it out to remove it. It's OPD procedure.
So why the
फिर से ले लेंगे. हमारे पास पेशेंट्स हैं जो हर बार खाने आ जाते हैं हर 6 महीने.
वो गल के निकल जाता है.
Patients have lost massive weight. Some I have lot of success stories. 70 किलो कम किया हुआ है लोगों ने.
नहीं, इंडिया में 2 ही चीजें तो खुल रही हैं सर. सबसे चमकता हुआ दिखेगा तो ईटरी मिलेगी आपको और नेक्स्ट बाय उसके हॉस्पिटल मिलेगी. So there are 2 things which are coming up.
And I have also data pre-marriage seasons में we have been approached by these marriage planners. कि पूरी एक marriage में all 40 wants to do it 3 months before the marriage so they can look good. So it's a big thing. Plastic surgeons are not allowed in India to use it because anybody who uses it should know endoscopy. That's important because if the patient cannot tolerate it, you have to remove by endoscopy. So unfortunately, अभी ये सिर्फ उन setups में है जहाँ endoscopy की facility आप justify कर सके available. Oh, I have 2 plastic surgeons who work very busy. They are more busy than me. I have 2 very good plastic surgeons. In fact, we were the first one to start bariatric plastic surgery in India. We get patients even from other bariatric surgeons. They have started to love me more and very busy. initially I was doing a lot of these body contouring, abdominoplasties, breast, thigh, but now we are busy, we have 2 plastic surgeons, so they do it. Very good.
So my query is about the balloon procedure. So what is the fate of the balloon? Will it pass in the
Yeah,
stool?
it passes. So balloon has a small suture inside.
Okay,
It melts and in 4 months and balloon automatically passes in motions.
Okay, sir.
So you have to do nothing.
Okay.
Just come to me, swallow it and go away. That's it.
Okay, sir.
It's as simple.
Sir, what is the basic procedure? What is the basic mechanism behind that?
The balloon is a space occupying
Yes, sir.
device.
Yes,
It's
sir.
a space occupying device inside the stomach. You feel full early.
It will reduce the
Yes, you
satiety.
will. It will give you early satiety.
Early satiety. Okay, sir. Thank you, sir.
Sir, we do not have any malnutrition even with bariatric surgery now. The length of the human small intestine is from 400 centimeters to 1200 centimeters. We never bypass more than 150 centimeters. So most of my patients have constipation. We have very common, not malabsorption, but we have multivitamin deficiencies. And that exists universally in patients who even do not undergo bariatric surgery. Even in patients who have drugs, so we give multivitamins and ask them to take a lot of protein, each and every patient. It's not specific to bariatric surgery. In India, B12, D3, iron and calcium are deficient. So this is a very good study. Patients who come to your clinic, specifically female patients for a lap chole, test their serum albumin. You will get the real story. Everybody is deficient in proteins, multivitamins, so everybody should take it. I mean, irrespective of bariatric surgery or anything. You have to take it lifelong. Yes. Yes, yes. I have a lot of them. So the best way is that if they have recurrent hypoglycemia, the first step is actually, we want them to develop recurrent hypoglycemia, because if they dump, they change their food habits. So they shift from a carbohydrate diet to a more protein-based diet, to a more Mediterranean-based diet where they eat more salads and this thing. But if they do not change their lifestyle and they eat carbohydrates and have recurrent hypoglycemia, we have to do continuously ambulatory glucose monitoring for 2 weeks. And if they have blood glucose going below 50 more than 3 times in a day for consecutively 2 weeks, we have to reverse it. Or we have to go in with an endoscope, take bites at the outlet to reduce the dumping, narrow the outlet to reduce the dumping. So that has to be done. Yes, yes. We use, but it would sometimes it works, sometimes it.
There are a good number of my patients on carbos.
Carbos it works, sometimes it
And
doesn't work.
sometimes they have reactive hypoglycemia, so I put them on pioglitazone sometimes, though they are the ones who are losing weight. But sometimes they respond well to it.
Usually in post-bariatric hypoglycemia, the algorithm is dietary changes to reduce fast consumption of
Yeah.
carbohydrates, continuous glucose monitoring of your lifestyle, acarbose, triatide agonists,
Yes.
diazoxide, and in rare people, pegfilgrastim. But interestingly, one of the things that's under study right now at the Joslin in Harvard is GLP-1 receptor agonists, which you'd think would be silly because the mechanism of post-bariatric hypoglycemia has to do with hyperstimulation of GLP-1. And why would you give a GLP-1? Evidently, when you give it medicinally, its impact on gastric emptying apparently is more important than its impact on GLP-1 stimulation, which is already maxed out. So it's being tested to see if this might be helpful in post-bariatric hypoglycemia. But that's a study underway now.
So I think we have done that. Acarbose, not very impressive. Not
yeah,
many
that's
patients
just the first
respond.
line.
Yeah, pioglitazones, we have not have a lot of experience with that. I think endocrines can tell you. Sachin sir,
The
I've seen.
insulin levels are very high, phenomenally high, with a sugar value of around 100. If someone is having an insulin value of somewhere around 40, 45, I come across such kind of patients. They do respond to such kind of.
Why would you use pioglitazone? I don't understand that.
Maybe that is true, but just for a symptomatic relief initially, the patient has already lost weight, but now he is suffering and is dying because of hypoglycemia.
Yeah.
So I am not left with any of the options, and he is not ready for a revision surgery.
The problem is
That
they don't
is
agree for
something-
revisions
Yeah,
because they are
That is
scared of weight
something,
regain.
challenge in India.
It's also not clear that this will get better always after revision. So at least in the literature, with post-bariatric hypoglycemia, when you take apart the gastric bypass, it doesn't necessarily get rid of the PBH.
So there's a technique there also. When we do the gastrostomy, I do not fire the entire length of the stapler. And plus the pylorus take a little bit of time to Again, it's contractility. These patients do respond, David, well. I mean, the dumping decreases drastically.
But it's a pretty minor I mean, in terms of percentages, it's a pretty minor effect.
2%.
2%, I'd give that, maybe, I would have said 1, but okay, somewhere around there.
Yeah.
Hey, well, I have this microphone. Can I make a comment about bariatric surgery? Regarding temporal trends and what may happen down the road, I just want to bring your attention to the last slide I showed. It's U.S. data, but in a publication by the Global Burden of Diseases study, which is this very impressive global epidemiologic study, they published in Lancet about 6 months ago, looking at temporal trends of obesity in every country around the world. And you know, it's just an inexorable rise, predicted to keep going until 2050. And what happens in my country is basically foreshadowing what's going on in your country. So you're to follow. You guys are still pretty low in obesity percentage-wise, but in terms of absolute numbers, you have tons. And you recently surpassed China as the country with the most people with obesity who are young. The biggest temporal rise was from this paper published in Lancet Diabetes Endocrinology 6 days ago in the super obese, people with BMIs over 60, that are just completely taking off. Presuming that follows in your case, those people, you know, they're not good candidates for any of these drugs. They're just not enough.
Yeah.
So the land for metabolic surgery is going to exist for a long time.
Yeah. And I think this is my take. I think the procedures like sleeve will not be the main procedures. We would see the duodenal switch coming in again.
Oh yeah, for BMI over 60.
For BMI over 60. I've been doing duodenal switch now, the SADIs now.
Sure.
For BMI over 60, people criticize me. Yeah. We have very good results.
Even
but criticism is by those who cannot do it, so I agree.
Even
I
gastric
accept
bypass
that.
is not enough.
So the DMR, we did the trials already. I cannot present the exact data, but we have been able to put patients off insulin. And the device is by a company known as Fractal. They already launched this year in DDW. Will be available in India from next year.
Mohit?
For metabolic reasons, yeah. It's going to work. It's going to be another area which will go from surgeons to gastroenterologists, the diabetes. Because why it will be a big area for gastroenterologists, because now this is very interesting. You know, Eli Lilly makes a ton, billion and trillions of money by using insulin. What DMR would do is they would remove patients from insulin and put them on a GLP-1. So this is going to be a big area of gastroenterologists if they have learned to do good DMR. It takes around 45 minutes to do it nicely. Yeah, it will take less time, 25, 30 minutes. Yes.
We have seen a lot of patients coming to us who has been operated by you with gallstones. So
yes.
Incidence of gallstones after bariatric surgery is significantly high.
Significantly.
First year I think it is 10 to 50%, subsequently also. So nowadays, is it recommended to go for simultaneous incidental, something like anticipatory cholecystectomy in these patients?
Only if you bypass more than 250 centimeters of total length of intestine, it's recommended. If you bypass less, it's not recommended. The rule, so there is no guideline, to be honest with you. Yes, correct. No, we have done it when we are doing duodenal switch. Is against that, correct. Cholecystectomy, correct.
But sir, the incidence is pretty high, and basically we can't do.
See, actually, इस पे बहुत debate हो चुकी है. To do a cholecystectomy in a super obese patient has lot of CBD injuries and lot of complications. He would know more about it. So this is all sorted. But I'm telling you the recent regulation which has come by the society and consensus. Anytime you bypass more than 250 centimeters of intestine, which we do it in a duodenal switch, you can do a concomitant lap chole if you are comfortable and you are having good access to the anatomy. If you feel that you are not comfortable, there is a lot of fat, you cannot see the anatomy, leave it there. Do not try because you will do more damage. And even though the incidence of gallstones is high post-bariatric surgery, the patients ending up with gallstone pancreatitis requiring admission or ending up having mortality because of necrotizing pancreatitis is 0.001%. So, you know, now you got the answer. We cannot you will have a lot of CBD injuries coming even with bariatric surgeons.
And Sachin, what is role of this new medicine, setmelanotide, which is something like, which is equivalent to something like in setmelanotide?
Setmelanotide.
Yeah.
Setmelanotide.
Yeah.
It's for congenital obesity.
I can answer that if you.
Yeah, yeah, you can answer.
Setmelanotide is a melanocortin-4 receptor agonist, only useful in people who have defects upstream of the melanocortin-4 receptor in the leptin signaling pathway. So if, leptin works by connecting to its own receptor in the hypothalamus, and then that causes POMC to cleave out melanocortins from the POMC, prohormone convertase cleaves out POMC from the POMC gene. The melanocortin that's secreted talks to the melanocortin-4 receptor, and it sends the satiety signal that leptin does. If you lack anything in that pathway, you weigh 1,000. You're incredible obesity. These are really rare. So if you restore the melanocortin-4 in any defect prior to that upstream, then that's a cure. So leptin null mutations, leptin receptor, prohormone convertase, POMC itself, or something called, there's one that eliminates the whole area of the, that's called SIM1 or something like that, SIM1. But those are really rare. But in those,
So not a mainstream drug.
Not a what?
It's not a mainstream drug.
It's,
not
it's a
at all.
super rare thing. And unfortunately, in this pathway, the most common defect is the melanocortin-4 receptor itself, representing 3 to 4% of severe obesity. But that doesn't help with setmelanotide because that's a ligand for that receptor. If the receptor is damaged, that doesn't help. Well, I have this thing. I want to make a comment about duodenal mucosal resurfacing with the gastroenterologist. You're probably familiar with the fractal technique of that, which you said is kind of challenging.
Yes.
That's the most prominent one in the field. It's a thermal ablation of the duodenal mucosa, and it requires a duodenal, a mucosal lift.
Mucosal lift technique.
Yeah, to protect the underlying area from the burn that they basically do. That's okay. There's a better technique to do the same thing that's being pushed by a company called Endogenics, and they cause an irreversible electroporation of the tissue, which slowly causes death over the next 7 days through calcium channel disruption, and that is replaced by it doesn't cause necrosis, it causes apoptosis, and should be replaced with regrowth slowly without scarring. I think this is a better technique.
Yeah.
It's going to be a lot easier for the surgeons not to have to do the mucosal lift, and you should be able to do it more often over time without scarring. So endogenics instead of fractal, my particular perspective, but both are interesting.
I think endogenics is not as well funded at this point in
It's
time.
not.
So yeah, so
They're
Fractal is funded, so they will get some funds before they come to India, because at the end of the day, they will all be registered as a phase 2 clinical trial here.
Sure.
Fractal, we just completed that.
Yeah.
With endogenics, they say that they don't have funds, so they are still trying to explore the US and Europe market.
Yeah, fractal
They
is
have a
ahead
C
of
mark
the-
lined up, but yeah, 3 years,
It's ahead of the game.
2 to
But
3 years.
Theoretically, the endogenics is a better product.
Yeah.
So, yeah, please.
I just want to know that is there any Muse modify early warning sign? Is there any modify early warning sign that when we started this process? So is there any like we have to trace the patient's health like deficiencies and all?
Yeah, we have to do all the tests.
As I belongs to my nursing.
We have to do a lot of these tests at 6 months, 1 year, all multivitamins, protein, liver function tests. Some of these patients have propensity to go into liver failure also if they lose a lot of weight. And we will see this happening even with tirzepatide now.
Yeah.
Once you have massive weight loss, you have multivitamin deficiencies, trace elements, liver function test gets deranged. So we have to.
Only lab investigations.
Yes.
So, and what about the vital signs?
Vital signs,
ECGs and all?
No, ECG we don't do. Usually, if you have a patient who, vital signs monitoring will be required for a patient who have either dehydration, very frail, or have chronic renal failure, but they are very less.
RBS and all?
No. Not always. See, these are the patients which are actually we are seeing on the OPD basis. So they don't require such kind of investigations as and when they will come for follow-up. the requested things will be done as and when required.
And symptomatically, if you have a patient in shock after bariatric surgery, or for that matter after tirpacetide, there has to be a cause behind that thing. Either he has lost a lot of blood, or maybe he has a leak, or maybe he has a similarly with tirpacetide, if you have a patient in shock, why should that happen? Maybe the patient had severe abdominal pain and that was pancreatitis, and now because of necrotizing pancreatitis, he lost a lot of fluid, third spacing, and so this is not going to happen in a day's time. It takes time.
So I think please keep your questions. We'll have one interaction and panel discussion after the last lecture. So that will be, I think, keep your guns fully loaded so that we can have a detailed discussion. Thank you, boys. Thanks a lot. So अभी तक तो ऐसा लगने लगा होगा कि there are things like there's nothing like apart from bariatric surgery and these medicines, there's nothing like which we can do in our clinical practice. But dear friends, what is the main crux of therapy for weight loss is, first you'll have to start the lifestyle intervention. Diet and exercise is still the crux of it. There are many papers which say before going to bariatric surgery, you'll have to prove yourself with respect to weight loss by diet and exercise and the lifestyle modification, because that is something which you will be needing to continue after bariatric surgery. So this is something which people don't like, and when we press a lot, so they say कि यार डॉक्टर साहब तो बड़े rude हो गए. So this is again a common problem which we come across in our clinical practice. There are many thousands of cases who come to us. They don't want to undergo the knife. They don't want to have a surgery. They don't want to have the costly medicines. And they have been to all of the dietitians. They have been to all of the places, and they come to us with a hope that I have a magic wand and I will just do it and they will lose weight. So this is our problem in clinical practice. And dear friends, there are many causes. There are many causes apart from obesity. The cause of obesity is not always the routine obesity which we see. There are monogenic causes of obesity, as David was talking about. The MC4 mutation is one of the commonest cause for obesity. So we have a drug which sir was asking. So these are the drugs for those rare things. We have got syndromes like Prader-Willi syndrome, Bardet-Biedl syndrome. There are many syndromes. They don't fall under the hormonal canopy, but there are some hormonal causes also. There are some causes which we might not be addressing it just because कि हमें लगता है कि हर मोटा आदमी कहीं ना कहीं, ये तो भंडारी जी का ही पेशेंट है, कहीं ना कहीं मोटा आदमी उसे कहीं ना कहीं इसको केवल GLP एनालॉग्स ही देने हैं. तो ऐसा नहीं है. There are many other areas in our clinical field which are to be actually ruled out before addressing your patient for surgery or any kind of the analogs which you have. So I'll be talking about that. While the majority of the obesity cases are related to lifestyle factors such as excessive caloric intake and sedentary behavior, a subset of individuals experience secondary obesity which arise due to identifiable medical conditions. Among these, endocrine disorders are important, yet often under-recognized causes. So they typically present with distinctive clinical features. So it will be a case-based presentation. So these are all published cases. So it's a report of 38-year-old women who presented to a rural hospital with severe headache and visual disturbances. History of fibromyalgia, insulin-dependent type 2 diabetes, hypertension, psoriasis, and psoriatic arthritis, multiple comorbidities. So the physical features: abdominal obesity with stria, thin limbs, facial readiness, excessive sweating, and fat above the collarbones and on the upper back, buffalo hem, dark axillary pigmentation. I think the diagnosis is very clear, but often missed. Often missed. This is something, there is an entity you can say there is an entity called subclinical Cushing's also. It is often missed. So the classical features of a Cushing's syndrome. The further investigation, MRI showed, but there was a catch in this case, a heterogeneous pituitary lesion consistent with hemorrhage into the gland. It was a case of pituitary apoplexy. Large tumors, they tend to bleed more because the kind of vascular supply they have. it is not as per the normal pituitary gland. It is very fragile with respect to bleeding. So it presented with pituitary apoplexy. So her symptoms mostly resolved during hospitalization without specific, mostly there are times when the people, they resolve with their symptoms after apoplexy. It becomes that is again a kind of accident which turns out to be an opportunity for the patient. But it was not like that. So over the next few weeks, she felt better with improved glucose control and reduced insulin need, lower blood pressure. A repeat MRI 5 months later showed no remaining pituitary mass. It was strongly suspected that she had Cushing's disease due to an ACTH producing pituitary adenoma, which had hemorrhage, causing acute symptoms and subsequent tumor disappearance. 15 months after the initial suspicion of Cushing's disease, diagnosis was finally confirmed, and cortisol and ACTH levels were high, and there was no non-suppressant. The low dose dexamethasone suppression test was not sufficient, and the MRI showed a 2 millimeter pituitary adenoma again, which was abutting the cavernous sinus. Whenever a lesion abuts a cavernous sinus, the possibility of getting it operated is less. So due to the location of adenoma, curative surgery was not possible. So post-operative course, persistent disease, high ACTH, cortisol, ketoconazole, gamma knife radiosurgery was done abroad, and the conditions worsened. Melanosis, HbA1c was 9.9, myopathic features, frequent falls, anxiety, depression. See the kind of problems the patient is undergoing. Bilateral adrenalectomy was planned. This is something which was a very primitive measure, which we usually, since I was at All India Institute, New Delhi, we had got a series of patients who went for bilateral adrenalectomy. Indication was uncontrolled cortisol. These are very sick patients. In West, people will say, ki, nahi, you should not do bilateral adrenalectomy. But in India, we come across such kind of situations when we are forced to do bilateral adrenalectomy. So, pardon, sir? Yeah, we usually go give ketoconazole, and all those drugs are given in our clinical practice, but we don't have that. So it was uncontrolled cortisol production, and outcome HbA1c improved and better well-being and glucose control. However, she developed Nelson syndrome, which was marked by high ACTH, skin darkening. Patient पूरा काला होके आ जाता है, और उसके बाद भी जो there is enlargement of tumor sometimes also. Secondly, again she went for gamma knife, and the 8 years after diagnosis, no final outcome was no tumor recurrence, ACTH below normal, well-controlled diabetes, BP, and resumed hobbies and daily activities. So dear friends, we can have a patient who is suffering from obesity. He or she might be a case of Cushing's disease, and see the long course of treatment the patient had to undergo. So there are many other areas, there are many other permutations and combinations you may come across. So every time, whenever you see a case, it might be a case of Cushing syndrome. It's a rare but important endocrine cause of central obesity. Classic signs like moon faces, abdominal stria, buffalo hump, thin limbs, facial hirsutism, acanthosis nigricans, caused by excess cortisol, often due to ACTH secreting pituitary adenoma. And diagnosis involves clinical suspicion, that is foremost, hormonal assays, dexamethasone suppression test, and MRI brain. So sometimes you may come across. Let's come to the second case. A 28-year-old woman, unmarried lady, complains of progressive weight gain over 5 years, irregular periods, facial acne, hirsutism, fatigue, and difficulty in losing weight despite lifestyle efforts. This is a common scene in our clinical practice. They come across कि डॉक्टर साहब वजन ही कम नहीं हो रहा. So no history of diabetes or hypertension, BMI is 33, vital signs are normal, signs on examination, acne, coarse facial hair, acanthosis nigricans, central obesity with fat distribution around abdomen. This is very common amongst girls. Say they come across with that kind of picture. Just a week back, there was again a young girl who had that dark pigmentation over the face. And the mother was concerned this is because of insulin resistance. This is how now they are AI trained gentlemen who come to us, the AI trained attendants. So when I say that I'm taking care of, I know this is because of insulin resistance, she got disheartened. This was a week back only. So the message was that Dr. Sachin was very rude. Though I was trying to correct, let's work hard with respect to the measures which I wanted to take for weight loss. But she was more interested in insulin resistance. This is how the things come in. So this was a case. Initial misinterpretation, initially labeled as lifestyle-induced obesity and stress-related amenorrhea, advised on diet and exercise with no further evaluation. Only partial symptomatic relief with topical acne medications. This is common. They come with these kind of acne. Investigations triggered by clinical clues due to persistent symptoms. Further workup was done. Hormonal profile, elevated LH-FSH ratio, elevated testosterone, normal prolactin and TSH. Pelvic ultrasound, it was enlarged ovaries with multiple peripheral follicles. You know what is the diagnosis. So the Rotterdam criteria was used, and this is showing oligoanovulation, clinical and biochemical hyperandrogenism, and polycystic ovaries on ultrasound. Sometimes the diagnosis of polycystic ovary syndrome has been labeled in majority of our cases. There are actually cases of simple obesity who have the features of polycystic ovary syndrome just because of the obesity. But many of the times we come across patients where we are, even after correcting obesity, there is something which we are missing. So this is a kind of thing, the pathophysiology, PCOS and obesity, insulin resistance, stimulates ovarian androgen production, disrupts ovulatory function, contributes to fat accumulation, especially abdominal, vicious cycle of obesity, worsening PCO, and vice versa. The vice versa thing is something which is kind of enigma for us. So the management strategy, lifestyle intervention, this is what we do, the blah blah kind of thing, and over the top of it, now Monjaro has also come in our clinical practice, so it will find its place. So this is how, after follow-up of 6 months, 5 kg weight loss, menstrual cycles are the first to get regularized. The moment you lose weight by 5 to 10 percentile, the menstrual cycle improves. Acne improved, hirsutism reduced with laser surgery, and patient more motivated and confident. So the association between PCO and obesity, between 30 to 75% of women with PCO are obese. 60% of lean women with PCO have increased body fat and central adiposity. And the cause of obesity in PCO is not known. So this is how we are stuck up with something. And these kind of cases, they come up, and when we do little bit of, we try to tighten those screws which are somewhere loosened somewhere, they say we are very rude people. So that is the problem difference. So in clinical practice, मुझे कई बार डर लगने लगता है obesity वाले patients को. So this time, nowadays I have made a disclaimer कि I'll be talking very straightforward. मैं सीधे बल्ले से batting करूँगा, and you'll have to bear up those things. So this is how the things are. क्योंकि आप you'll have to cater those patients, you'll have to address those patients. But there are lot of fallacies. Case 3 again, about 10 years, sex male, known case of craniopharyngioma. This is how the case was. Dr. Manish was asking about the drug. So that drug might fit in this case. History of present illness, progressive weight gain, 20 kg in 6 months post surgery, despite normal or reduced food intake, suggestive of metabolic dysregulation. Reduced physical activity, easy fatigability, sedentary behavior, increased daytime sleepiness, hyperphagia, and behavioral changes. So this is a case of craniopharyngioma. Post-operatively, the patient is having all these complaints. Was diagnosed at the age of 9 years, underwent tumor resection, and on hormone replacement therapy, thyroxine, desmopressin, and hydrocortisone. Examination findings, obesity is there, and round faces, abdominal obesity, normal secondary sexual characteristics, and signs of hormonal deficiency. So investigations like central hypothyroidism was established, adrenal insufficiency, diabetes insipidus, neuroimaging MRI, postoperative changes in hypothalamic region. Resting energy expenditure was decreased on indirect calorimetry, and so the diagnosis was hypothalamic obesity, secondary to a craniopharyngioma surgery. This is again, so you may come across a case of obesity who is not a case of simple obesity, might be case of a hypothalamus which got injured while post-surgery after cranial, even the involvement craniopharyngioma itself can lead to this. So this is again a problem. So this is how the case was, and this is how the closer proximity of hypothalamus is. And so the lifestyle management was planned, physical activity, pharmacological therapy like GLP receptor agonist, and the hormone replacement therapy was continued, psychological support and behavior therapy and long-term follow-up, multidisciplinary things were there. So here the role of such kind of newer medicines can come in, because these are the patients who suffer a lot. the treatment of hypothalamic obesity with GLP analogs. This is again a new paper. And the result, GLP analogs potentially offer a new approach to treat hypothalamic obesity. And there is a need to certify patients who are more likely to respond. So people are trying GLP analogs in hypothalamic obesity also. Yes, sir.
Another interesting thing, going back to the prior question, is setmelanotide is also being
Yeah, that's what I just pointed out. That is again which I have not included in this.
Yeah, I mean, it's actually being tested by Christian Roth.
Yeah.
He's a colleague of mine at the University of Washington.
Yes.
And it depends as to whether that'll be successful on your individual case, whether the damage was to the arcuate nucleus only, or whether it also involved the paraventricular nucleus of the hypothalamus. If the latter, setmelanotide won't work. If the former, setmelanotide should be curative.
That's great, sir. So the summary of metabolic and clinical findings involved in dysregulated energy balance in hypothalamic obesity, altered reward, food reward, or decreased catecholamines, decreased physical activity, deficient melanocortin signaling, hyperleptinemia, hyperinsulinemia. So there are multiple things, and as Dr. David Cummings has rightly pointed out, you will have to give the drug as per the deficiency and as per the involvement. So case 4 is a female, 12-year-old female presenting with excessive weight gain over the past 1 year. Gradual weight gain despite no significant change in appetite or physical activity. Fatigue, lethargy, constipation, dry skin, cold intolerance, poor concentration, academic performance. Menstrual history not yet attained menarche. What is the possibility? You come across, yeah, that is something which is again a problem. So no history of chronic illness, mother with hypothyroidism, there is a history. No history of diabetes or autoimmune disease. And physical examination, weight is greater than 97th percentile. Appearance, puffy face, dry core skin, bradycardia, delayed reflexes. This is something which we commonly see. And see the level of TSH, it was 16. So it was a case of subclinical hypothyroidism. And T4 was also low, overt hypothyroidism. Anti-TPO antibody was also positive and suggestive of Hashimoto's thyroiditis. And so sometimes primary hypothyroidism presenting at obesity, this is something which I have pointed out in small letters just because sometimes it becomes a fallacy also. People say कि मुझे hypothyroidism हो गया, that's why I'm obese. That is a fallacy. But if you have hypothyroidism and overt hypothyroidism, there might be a weight gain of 3 to 4 kgs, and which usually resolves after correction of hypothyroidism. So, इसमें पूरा गोल चक्कर हो गया. At one point of time, the patient might say कि मुझे hypothyroidism है, मैं दवा ले रही हूँ, फिर भी मेरा वजन कम नहीं हो रहा. It is just because of the illness I have. That is a fallacy. That is a myth. But if you have non-corrected hypothyroidism, please correct it and see for weight loss. And just assure he or she will have a weight loss of 3 to 4 kgs, not more than that, just because of the diuretic effect of the molecule. The rest is something वो आपने खुद जमा किया. कहीं ना कहीं you have, that is your contribution towards your weight, and that has to be meant somewhere. So this is how we did it. So obesity in children may be the first sign of an underlying thyroid disorders. Hashimoto's thyroiditis is common autoimmune cause of hypothyroidism in adults. Positive anti-TPO antibodies and elevated TSH with low free T4 confirms the diagnosis. So case 5, chief complaint was poor height gain with increasing weight over 2 years. And the child is 8 years, just 8 years. मोटा हो रहा है पर ऊंचा नहीं हो रहा. The growth concerns like parents noticed that a child was shorter than peers. No increase in shoe or clothing size for the 2 years. छोटा बेटा भी बड़ा हो गया. छोटा बेटा जो 6 साल का है, now वो 8 साल के बच्चे से भी बड़ा होने लगा, ऊंचा होने लगा. तो ये parental concern आता है. Sometimes you may come across such kind of cases. So no significant change in appetite or activity, no history of chronic illness, medication or CNS trauma. Birth and developmental history, birth history was full term, normal delivery, again developmental milestones were normal, no neonatal hypoglycemia, jaundice or micropenis. Family history, mid-parental height within normal range, no similar history of short stature or endocrine disorders. Height is less than 3rd percentile, weight is 75th percentile, BMI is elevated, growth velocity is less than 4 centimeter, body habitus is truncal obesity, puberty is prepubertal tenor stage 1. What is the possibility? You come across a child who is who's not growing and who's growing with respect to dimensions. Yeah, the growth hormone deficiency is again missed. अब हो सकता है आप बोलो कि हमारा बच्चा बहुत ऊंचा हो रहा है, बहुत मोटा हो रहा है, ऊंचा नहीं हो रहा, and you might miss it as a case of simple obesity. So this is also a possibility, and isolated growth hormone deficiency presenting as short stature and obesity. So in adults, growth hormone deficiency is associated with increase in fat mass, especially abdominal obesity and decrease in lean body mass. Growth hormone treatment in growth hormone deficient adults have been shown to decrease the fat mass and promote growth of lean tissue, but no effect on overall weight. So this is how the child was managed. This is again a case presented with obesity, round face, short stature, brachydactyly, and learning difficulties. Chief complaints was progressive weight gain since childhood, occasional muscle cramps and tingling in the hands, poor school performance, scholastic performance was not good. BMI was greater than 95 percentile, height was below 3rd percentile, round face, central obesity, brachydactyly, Shostak's and Trocheus were positive. These are very picturesque signs. They are positive, so that was because of hypocalcemia. No goiter, normal pubertal staging, and relevant history, no family history of endocrine disorders, no significant perinatal history, development delay was noted since early childhood. देखिए अब ये दिस इज अगेन विच इज वेरी कॉमन, इसलिए आप पेशेंट्स को देखने से ये हम लोग कई बार देखते हैं, एंड वी कम अक्रॉस दिस काइंड ऑफ शॉर्टनिंग ऑफ द 4th and 5th phalanges. So it is typically seen, this is X-ray is typically showing, and the serum calcium was low, phosphate was high, PTH was elevated, and TSH was elevated with normal free T4, vitamin D was normal. So radiological findings was hand X-ray, shortening of the 4th and 5th metacarpal, Albright's hereditary osteodystrophy. What is the diagnosis? Pseudo-hypoparathyroidism type 1A based on biochemical evidence of PTH resistance. PTH यहाँ कम नहीं है, PTH high है. The phenotypic feature of Albright's hereditary osteodystrophy. So sometimes obesity can have an endocrine cause, a rare endocrine cause which is telling you on physical examination कि मैं ये हूँ, but you'll have to identify it. So that is something which is very common. That's why I kept this case. And pseudo-hypoparathyroidism linked to obesity, and obesity in PHP1A is due to GNAS mutation after GS alpha subunit, leading to resistance to multiple hormones including PTH and TSH. So there are cases in endocrine illnesses where you have very high values of that particular hormone and the effect of that hormone is low. PTH is high and the calcium is low. Sometimes you come across such kind of resistance in endocrine practice. So the management plan, calcium, vitamin D, morning and treatment associated with hypothyroidism. So these were the things which were done. So the case 7 is again a rare case which I just saw, so I thought why not to include it. Age is 6 years, female, previously healthy, normal development until till 3.5 years of age. History of present illness, rapid onset obesity. It's a new term. I think there are people who can explain it. Began suddenly at the age of 3.5 years and weight gain of 10 kg over 6 months. Hypothalamic dysfunction, hyperphagia, early signs of central hypothyroidism, episodes of hyponatremia, and poor temperature regulation. These were the things we had. Hypoventilation, sleep disorder breathing, snoring, cyanosis, deep sleep, again daytime somnolence, required polysomnography, confirmed central hypoventilation. Autonomic dysfunction, constipation, abnormal sweating patterns, pupillary abnormalities, and endocrine evolution, low TSH and T4, abnormal cortisol rhythm. MRI, left suprarenal mass showing a contrast enhancement of left adrenal mass, which was confirmed on histology to be a ganglioneuroma. So it was again a very interesting case. So the molecular analysis of PHOX, it is a published case, so I took it from the literature, was performed to rule out congenital central hypoventilation syndrome with the rapid development of obesity, disordered water balance, hyperprolactinemia, and absence of PHOX2B mutations. Our patient's diagnosis was confirmed to be this ROH head neck syndrome. So this was a new thing which I did not, before making this lecture, I was also not very much aware of it. So this Rod-Dett syndrome is a rare disorder of respiratory control and autonomic nervous system regulation with endocrine abnormality and rapid onset of obesity. So the diagnostic criteria they have given it, and it had rapid onset of obesity, evidence of hypothalamic dysfunction, central hypothyroidism, growth hormone deficiency, delayed or precocious puberty, and features of autonomic dysregulation. So sometimes rare syndromes can also present. So obesity isn't always obesity. Not all obesity is lifestyle related. Endocrine causes should be suspected in atypical presentations. If you have sudden weight gain, the child is not growing, if the problem is with respect to thyroid, if the problem is respect to adrenals, if the problem is respect to some other, there is some skeletal deformity. These are the indicators where you should look for some other cause apart from simple obesity. So obesity isn't always obesity. Thank you. Thanks a lot. So we are already late, and so I invite Dr. Mohit Bhandari and Dr. David Cummings for panel discussion, and now the house is open for questions. Please fire us with your questions, and the masters are there to answer it. So you can ask whatever you want, because this is again a big opportunity to have David over here, and as you all know, Mohit is the highest volume bariatric surgeon of India. So let's have some discussions regarding bariatric surgery, the GLP molecules, obesity, and the kind of problems you face in your clinical practice. Yeah, doctor, please.
So regarding pediatric obesity, childhood obesity, like setmelanotide is approved for more than 6 years of age, and GLP-1 is still, it has not come into the guidelines for pediatric obesity. So if a patient comes to you at maybe 3 years of age with childhood obesity, what do surgical or medical management options do we have?
Well, first of all, I don't see children at all, so it wouldn't come to me.
That is true for me also.
I work at the Veterans House. Don't you see kids?
No, I usually.
You talk like a pediatrician there.
I was just enumerating those endocrine cases.
Oh, okay.
We do say pediatric endocrine cases, but not obesity.
So setmelanotide, you say, is approved for children, but
it is more than 6 years in the guidelines, but they have tried for 3 years as well, as I remember.
It would make sense for certain forms of childhood obesity in the leptin-melanocortin pathway upstream of melanocortin-4 receptor. It doesn't make sense for anything else. It wouldn't work in Prader-Willi syndrome or Bardet-Biedl syndrome or anything like that. For childhood severe obesity, you have to figure out the cause. I mean, the vast majority will be common obesity, and it's from the parents being obese, and then you treat it like any other form. If it's way out of proportion, the child developed obesity since infancy and is far greater than his or her parents, then you need to look into what the cause is and fix that cause. If it's BBS, Bardet-Biedl syndrome, by the way, setmelanotide actually is good for that, because the mechanism of obesity and Bardet-Biedl syndrome, there's about 50 of those syndromes, has to do with the leptin, it's a ciliary problem, and the leptin receptor doesn't get transmigrated from the cytoplasm to the membrane well without the cilia. So you treat something downstream of leptin, melanocortin-4.
And what is the youngest you have operated, sir?
I've done it on a 6-year-old.
But how well does, in monogenic obesities, like we've just mentioned, would metabolic surgery be helpful?
Yeah, so if you rule out all the other causes, like you said, if there are no other causes, like usually genetics is not involved, we have done on Prader-Willi syndrome, and these children, they get a lot of benefit. It was life-saving in a couple of children.
When I was a young investigator, I published a paper in Nature Medicine on Prader-Willi syndrome. It was the beginning days of ghrelin, and we measured ghrelin in a bunch of children with Prader-Willi and some other ones with unusual forms of obesity, and found their ghrelin levels were the highest that have ever been measured in anybody. And we wondered if maybe in the multi-gene defect of Prader-Willi syndrome, they have a dysregulation of ghrelin. But in hindsight, it turns out probably the reason the ghrelin levels were high is that everybody who has Prader-Willi syndrome, once they're recognized, they go on a restrained diet that's a lot less than they want to eat. So they're kind of like people with anorexia nervosa in terms of the reaction, and the ghrelin is just responding to them being under their natural weight. I'm not aware that ghrelin antagonists have shown any benefit in Prader-Willi. I don't know of anything that shows benefit in Prader-Willi, actually.
These are actually very gray areas. I have an experience of giving growth hormone to one of the Prader-Willi syndrome cases.
That makes sense for their growth hormone deficiency.
Yeah, the response was limited.
It won't help with their obesity.
Even at the best of the best institutes, our hands are somehow, somewhere, we are stuck up with the interventions which are there. So when it comes to pediatric obesity, we are, just a few years back, Mohit called me, there is a person with leptin, yeah, there was a child. So this kind of cases, they are very tricky. They are very tricky. MC4R mutation is also very common.
3% of severe obesity,
Yeah.
roughly.
I think it's tough to evaluate them because these genetic analyses are very costly.
Yeah.
And most of the institutes will not, they would refer them to us, and who will bear the cost of this?
The other thing is, I've helped sort of manage the care in conjunction with several cases of monogenic obesity in kids in India. Mufi seems to have a lot of these. In the cases where the leptin null mutation, we gave them leptin. That's curative, that's like giving a hypothyroid person thyroid. In the case of leptin receptor mutations, give them setmelanotide. And these monogenic obesities can be cured with replacement of what they miss. Unfortunately, that's super rare, and the only ones that are not crazy rare are MC4R mutations.
Yeah, they're not crazy rare, but
we don't have a thing downstream.
we don't like to have these kind of cases because hardly we are doing anything. That is the problem. As a clinician, we are frustrated when it comes to, when we come across such kind of cases.
MC4Rs also don't respond very well to bariatric surgery.
David, because I have never got that kind of mutation. It always comes negative.
I've only seen them because I've had patients referred through Mufi Dr. Ali. And
that Mufi's patient is circulated everywhere, and then
we've had one family with leptin null mutations, a woman with leptin receptor mutation, and a few others. But I think he gets everybody from India.
Now, simple question. In your multidisciplinary team, I think dietitian plays an important role. Now, there are at least 8 or 10 kinds of diets which are recommended. Any merit in any particular diet, and similarly the kind of lifestyle, some like intermittent fasting and all these things. So what do you advise your patients? What we have read from the literature is none of the diet actually superior to either of these things. So what advice you give to these people as far as diet is concerned?
No, it's a very good question. So actually they can take any diet they want.
His accent.
But at the end of the day, they
He's
should be in a
asking about the
negative calorie
diet,
deficit
the
to lose
prevalent
weight.
diets we have.
Any particular thing like Mediterranean diet is there or something?
Low calorie diet.
They can take any diet. To be very practical with you, they can take any diet they want. With bariatric surgery, they cannot eat. A patient with bariatric surgery for at least first 6 months cannot eat more than 800 to 1000 kilocalories a day. I can guarantee that, until unless he starts to go and takes sugar syrups, and they are obsessive compulsive patients. For rest all, any diet you give them, if they are not in a negative calorie, these diets even do not work for patients who are non-bariatric patients. The point is, whatever you eat, you have to be in a negative calorie deficit.
I have a very pivotal paper published in 2004 into one of 4 diets. One was modeled after Ornish or American Heart Association. One was specifically high protein, modeled after Protein Busters or Zone. And the last one was the Weight Watchers diet, which is basically sensible eating like your mother told you. Relatively small portion sizes and eat lots of fruits and vegetables. And then they studied them for a year on one of these 4 diets in a randomized trial. The results were very easy to take home. No diet works particularly terribly well. Most people lost a little weight, and we started to regain it after 6 months. No one of those diets was any better than the others. They were all equally effective. And the best predictor of any of effectiveness on any diet was how well they adhered to that diet. It only works if you do it. So my take-home message for my patients ever since has been, choose whichever of these popular diets suits your needs. If you can manage a low-fat diet, do low-fat. If that's hard for you and you can do a low-carb, do low-carb. And stick to it. Do the one that you can live with. And again, all of them are only minimally helpful. There's also the diet that's sort of promoted by the Direct study from Lancet a few years ago, but that's a fairly expensive thing involving meal replacements with a branded, what's it again? Yeah, with Ross Taylor.
So in India we have this something called as a herbal therapy.
Herbal, yeah.
Most of the patients, they take this herbal therapy. They have this herbs they give, and they send it to their home, and they reduce good amount of weight. But I have not seen a patient maintaining weight. So as you correctly said, they are not able to only things which are sustainable can work.
By the way, intermittent fasting is reasonably effective within this scope. I mean, no more so than any other diet, but it does promote some weight loss, and for people.
Again, David, intermittent fasting is effective only if the total calorie intake. You know, you are nil by mouth the whole day, and then during the when you break your fast, you eat 10,000 calories.
No, yeah, of course.
Then it is not effective.
It's all just basically.
This is what we do after fast.
These in the early days of low carb diets, I was around. I was a new professor, and Atkins was still alive, and he was selling like lots and lots of books. And we all thought, how could a low carb diet cause weight loss? Because inevitably you eat more fat, and there's 9 kilocalories per gram of fat instead of 4 in carbs or proteins. So there's more fat, more calories per spoonful of fat. So several of my colleagues found, whether it be low carb or low fat or high protein, make it relatively uninteresting to eat what you're allowed to eat. And you become, if you can only eat ice cream, pretty soon you're like, I want something other than ice cream. And you want what you're not allowed to have. So if you stick to the diet, you end up eating less.
LP1 and everything. That too is strength training. And gym-like thing, so motivational counseling should be for exercise to prevent that lean body mass.
Absolutely true. There are some studies now showing that the best way to mitigate the lean body mass with GLP-1s is resistance training, and the next best thing is high protein diet.
But you would realize that your patients on full dose of GLP-1 will not be even able to get up from the bed. They have so much of nausea. I told David this, that patients are not able to exercise while they are on Mounjaro.
Then we decrease the dose. We
have
come
to
down.
Decrease. We have to decrease the dose. Yeah. And then slowly with the decrease in dose, they should not.
Majorly, sometimes they are not even able to tolerate the
they are
drug.
not even able to
You'll
tolerate the drug. You have to stop it, and then
the drop rate is quite high.
There is one thing which I wanted
100
to
patients, 10 of them have to stop it.
Most of these patients should also take at least 1.5 gram per kg body weight of protein. Yeah. And it is very difficult to even take 1 gram per kg body weight of protein if you are not liking the protein powder. Yes. So the same thing which we had with bariatric surgery, patients, they develop aversion to protein powders. The same I am seeing with Mounjaro. They somehow, they say we feel so much of nausea when we see the protein. Maybe because it delays the gastric emptying, it gets stuck there for a long time.
And this 1 gram per kg body weight stands for high biological value protein.
Yes.
And most of the times we Indians are on herbal diet.
Herbal diet.
Weirdly high.
No, you can't eat that. You, the good hero who acted in this movie, Shiva.
Okay.
Sambaji.
Chava.
He was given 2 gram per kg body weight of diet. 4,000 kilocalories.
Yeah, he gained weight.
But he gained weight. But to gain muscle mass with 2 gram per kg body weight and 4,000 calories eating, it's not easy. You cannot eat that much amount of protein.
Yes.
It's really hard. You will have constipation. He had fissure 3 times. He told in the medical meeting.
Okay.
3 times he had fissure during that diet for 3 months. It's not easy. It affects uric acid level.
Rose like
anything and all these things.
Parental.
Yes.
What about this? I heard, I think the bioavailability of this oral drug probably is very erratic actually.
Very bad. Very bad.
Very erratic. That's why I think there's no clear-cut dose which is specified for
labeled-
oral drug.
yeah. He labeled that drug as a nausea drug.
Yeah, it's very bad. And,
Well,
and,
I
and
got
for
that
some
from him. I got
patients,
that from
some patients will have no effect, even with 14 milligram, and some with 3 milligram will go into the hospital with pancreatitis. We don't
Sometimes
like
there are
that
good
drug.
number of people, अगर आपको clinical practice में if you want to stick to your patient, that is a problem if you give a GLP analog. बहुत सारी negative counseling पहले ही करनी पड़ती है sir.
It will hurt your practice
Otherwise you will
initially.
lose your patient. That is again a problem with GLP analog. It is not easy. बहुत ज़्यादा परेशान होके patient हमारे पास आ रहा है तो he is ready to accept anything.
पर normal patient को
Primarily
नहीं
level
देना
पे आप कर दोगे तो वो गालियाँ देगा आपको. That is a problem. That is a huge problem in GLP analog.
At the
So
moment,
it should not be given at one go. It should not be given as the first drug because in Indian settings it becomes very difficult. You will lose your patient.
at the moment, injectable GLP-1s are much better than orals. There are some new orals coming through the pipeline that have been designed with very clever AI techniques, which hold promise to have more effectiveness with less nausea, but that's in
But
development.
I think injectable is much more convenient. We just need, now we have a monthly injectable GLP.
It is convenient for those who are injecting those, but
Yeah.
those who are taking the injection, they are not ready even for a single prick
But
once
one
in a
thing,
week.
just before we end,
When you guys get the pens, though,
if
they'll be really
anyone
easy.
is wanting to start Monjaro and keep it in their clinics, please develop a multidisciplinary team. All of you are very busy. Keep a team, keep a good psychologist, rule out all sort of psychiatric disorders. Keep good counselors, keep good dietitians, because if we are not following up with these patients, and we are just to start, obesity looks like a very sexy business now. Everybody wants to do obesity, but it will burn your fingers, and the other existent practice will completely go away. I did first sleeve gastrectomy in 2007. I had a leak. After that, till 3 months, I could not do even a single lap chole, because that patient was in the hospital for 4 months, and every other patient who used to come used to tell. So, you know, just like surgery, if you are starting Monjaro, keep a good multidisciplinary team, keep good people with you who can counsel, because obese patient is like a child. He'll keep on crying and you will get irritated, because if he keeps on calling you, you will say, yaar, 2,000 रुपए का injection लिखा, इतनी जान खा रहा है. But that is going to happen. But if you keep a good multidisciplinary team with and important is sensitivity training of your staff. They should not get irritated. Believe me, it's very good. Then you will progress. But just to keep Monjaro in your chemist, with your chemist, and मैंने लिख दिया पर्चा, it is going
Towards
to
the
fail.
lighter side.
You are going to create patients for me.
दिल्ली में महिलाएं अपनी पर्स में लेकर आ रही हैं वायल्स कि डॉक्टर साहब ये इंजेक्शन लगाना है.
and we have horror stories from Gurgaon. There are 4 mortalities already with necrotizing pancreatitis.
Oh.
The patient with Monjaro. Because they don't realize. They did not, and again off label.
हो सकता है 2 बार लगा लिया हो वीक में.
And I mentioned earlier, I'm concerned a little bit about the risk of pancreatitis in the South Asian population.
Yes.
Because
It's
you
high.
have
It's very high.
you have a baseline
Higher incidence
of idiopathic pancreatitis.
and you know our pancreatic duct, the
Nutritional, is that, I say is idiopathic, am I wrong?
Yeah, primarily we are malnourished with respect to the kind of diet we have. It is
exactly.
a reverse nourishment we have.
Specifically, what about your diet
We are
promotes?
overly nourished.
I think the GLP analogs
I
are
would
not
never
to be,
give.
Not to
I
be
are
would never
contraindicated.
give.
They say कि you should not
even
administer
DP4
if you have
inhibitors.
osteopancreatitis.
Even DP4
any
inhibitors,
cause, any
never.
cause.
One should never give.
It's an absolute contraindication.
Absolute
But there are
contraindication.
studies where they have, I think they have cleared DP4 inhibitors, sitagliptin and all.
So that's fine.
I have
But
not
it
heard
should not
about
be.
that.
In clinical practice, I don't prescribe.
Also, please palpate the thyroid gland before you give.
Yeah,
GLPs.
this is
Please
also
do
true.
this practice.
Why
We
do you
have,
do
we are. That's why. Yeah, because we
MTC,
have
but it
thyroid
is
swelling, we have
medullary thyroid
undetected
carcinoma
medullary
is not
carcinoma.
common, not very
I
common.
think we should palpate thyroid glands before giving it to.
Yeah.
Okay, I mean.
Sometimes you may, but you will not be able to palpate a MTC lesion. It is not very common. It's very difficult. Otherwise, then you will say कि you should give Monjaro before giving Monjaro, get a calcitonin done.
In fact, when we were using Ozempic for the first,
इतना
common नहीं है, but in US they are getting serum
Yeah.
calcitonin done.
Yeah, so
Most centers.
I agree.
Even my professors from All India Institute, they were saying कि palpate करो, calcitonin कराओ,
Calcitonin
फिर
कराओ.
Monjaro लिखो. So that is a very big problem then.
This said, however, there's not a lot of proof that
non-obese and diabetic. Cardiac patients हैं तो? फ्यूचर है सर उनमें. अगर मान लीजिए कार्डियो एथेरोस्क्लेरोटिक कार्डियोवास्कुलर डिजीज की पॉसिबिलिटी ज़्यादा है तो दे आर द वंस वेयर यू शुड गिव जीएलपी एनालॉग. इवन द ड्रग फॉर्मुलरी इज आल्सो गिविंग अ वेरी क्लियर पिक्चर. एएसवीडी के चांसेस है, गिव इट. जीएलपी एनालॉग दे सकते हैं
सर. एक बात अपने को जो बतानी है,
हाँ
आप दे सकते हैं. इनफैक्ट बहुत सारे कार्डियोलॉजिस्ट अभी हमारे पास आते हैं, दे वांट टू नो मोर अबाउट द ड्रग. और अभी जो केग्रिसिमा ट्रायल हुई है, दे आर असेसिंग कार्डियक सेफ्टी, सेमाग्लूटाइड विद केग्रिलिनाटाइड. उसमें विथ मी द प्रिंसिपल इन्वेस्टिगेटर वाज माय कार्डियोलॉजिस्ट. अगर उसकी कार्डियक सेफ्टी प्रूव हो जाती है तो जो आप क्वेश्चन पूछ रहे हैं, नॉन ओबीज डायबिटिक्स में केग्रिसिमा इज गोइंग टू बी लॉन्च, इट इज गोइंग टू डू वंडर्स. उसका एक ही प्रॉब्लम था, जो रिपोर्ट्स यूरोपियन रिपोर्ट्स थी कि इट कॉजेस कार्डियक इवेंट्स, स्ट्रोक, एनी वेस्कुलर एपोप्लेक्सी. तो अभी स्टडी पब्लिश होगी. बहुत रेयर स्ट्रोक्स. इट इज़ अ वेरी गुड ड्रग. आप जो बोल रहे हो वो होने वाला है. So I think Kegrissima will. I'm very hopeful.
And with respect to cardiovascular outcome, these molecules are very clear. इसमें कोई confusion question mark है ही नहीं.
So at least injectable semaglutide.
कंपैरिजन का सवाल ही नहीं उठा ना सर. जहाँ पे हार्ट फेलियर है वहाँ SGLT2 पे जाऊँगा. जहाँ पे एथेरोस्क्लेरोटिक कार्डियोवास्कुलर डिजीज का रिस्क ज़्यादा है वहाँ पे GLP एनालॉग. जहाँ दोनों है तो आप कमाई. आइडियली इसलिए मैं तो कमाई करूँगा. अगर मेरा GLP एनालॉग के पेशेंट है तो, और डायबिटिक पेशेंट है तो मैं तो बिना ऑप्टिका के यूजुअली आई डोंट सेंड दोस पीपल.
And semaglutide injectable is very, very safe for cardiac patients. Very, very safe. I mean, we have a lot of data on that. What do you say?
Sure, I mean,
Sustain
Sustain 6 was one that showed 26%.
Yeah, leader was the primary trial, which actually was a breakthrough trial. Then later on, it was carried forward by Sustain 6.
Sustain 6 was a 26% reduction of cardiovascular events in people with diabetes, and then Select was a 20% reduction in people without diabetes, also the same drug.
These are legendary trials, no doubt.
And again, this is not the sort of reduction you get with metabolic surgery, which is more like 50% reduction in major events. But not everybody wants to have surgery.
I think,
thanks a lot. Wait, as we get to, I have one question for the audience.
Yeah.
So as Mohit will tell you, I recently finished an interesting book about Indian history told in the lives of 50 legendary figures dating back to the Buddha and ending up with Dhirubhai Ambani. One of them was, I think his name is Charak. He was the he started Ayurvedic.
Charak was an Ayurvedic doctor, I think.
So my question to, yeah.
He wrote Charak something.
So my question is, how many people in your practice put their faith in Ayurvedic medicine, and is that a barrier to what you do, or do you work in concert with that? I'm kind of curious.
Very controversial question.
Is it common? In modern India, is Ayurvedic medicine? I'm told that a lot of people are fans of Ayurvedic medicine because
there is a huge patronage to Ayurvedic medicine in India nowadays.
Yeah.
But unfortunately, my take is that we lack the clinical evidence with respect to studies. There is no head-to-head comparison of any of these molecules with the present-day molecule and the effect and the treatment outcome. It is lacking. But the traditional medicines work. They do work.
Our regulatory board says that you cannot practice Ayurvedic medicine if you are practicing modern medicine. So those who are practicing in Ayurveda, they are different practitioners.
Yeah.
The modern medicine.
The problem in India is all these people who have done bachelor's in their Ayurvedic medicine, they keep adding allopathic medicines. That is the shortcut.
See, according to this book,
but primarily the concept of Ayurveda is very good. It was the first modality to identify your gut as one of the major cause of all illnesses.
See, according to this book, apparently it's quite popular nowadays because there are so many people in India. It's hard for them all to see their allopathic medicines on doctors on time. And so they've spread to this kind of chat room access to Ayurvedic doctors who talk with them over the phone. And they get tender, loving care when they can't get to you on time. Thank you for that.
They believe a lot. They have a
Thank you for
strong belief
educating me.
it doesn't lead to any kind of side effects.
It's probably harmless from what I read of it. For sure, you wouldn't want to use it if you had metastatic cancer. You wouldn't want to try that on. Oh, I see. I see. Okay. Thank you.
So I invite you all for the group photograph. We always have one group photograph before ending up.